It's a pleasure to invite all of you here today for this stroke symposium where we are going to discuss regarding the stroke care with our experts. So, before we begin this interesting evening, I would just like to wish everybody happy Dhanteras. And with that, let me introduce our chairperson for today, Dr. P.C. Gilwas, sir. Regarding, of course, sir is a eminent personality and doesn't require much of an introduction. But sir is a visionary neurologist and educator, serving as a professor and head of Department of Neurology since 2003. Sir is a fellow of the American Academy of Neurology with global contributions to neuroethics and patient care. Sir is the chair of the UNESCO Bioethics Unit, nurturing ethical leadership in medicine, past president of leading neurology societies in Kerala, inspiring collaboration and excellence. Sir is also passionate about teaching the art of science of neurology, shaping generations of clinicians. Thank you so much, sir, for joining us today. And yes, with that, we move to our moderator for today, Dr. Icha Poria, sir. Again, an eminent personality in the field of neurology. Sir is the director of neurology at Sahyadri Hospital, Yerwada. Sir is the first neuro ICU and neuro intensive care of Pune was built by Sir. He has been a pioneer in thrombolysis treatment for stroke in India. More than 300 public lectures and workshops on stroke has been taken by Sir. He is a member of Indian Stroke Association and the organizing president of StrokeCon 2012, the organizing president of ISA's Stroke School as well. Sir is the founder of Pune Strokes Group, ex-president of the Society of Neurosciences, Pune, and Maharashtra Academy of Neurology. Sir is a principal investigator for multinational stroke trials like Perform, BrainsGate, BG12, cortical venous thrombosis, Interact, etc. Sir has also been awarded as the health icon by the Times of India Group. Sir, it's a pleasure to have you here today. With this, I hand it over to Ichapuria sir and Gilbas sir to please address the gathering.
Yes, Dr. Gilbas, I think you can kick off.
Yeah. Good evening, everyone. It's morning here in the US. It's 5:30 in the morning here, and welcome to this very intriguing discussion on shaping stroke care. Now, stroke is one of the most dynamic and evolving fields of neurology, and I think we have almost the who's who of speakers across the country. So I think without much delay, we'll just go on with the talks. And welcome to this session.
The first talk, we have thrombolysis today, Indian guidelines and unmet needs. We have Dr. M.B. Padma ma'am who will take the same. Ichapuria sir.
Yes, Dr. Padma is well known to all of us, and she's a torchbearer in the field of stroke and neurology. And up to now, she was head of department of neurology at AIMS, but now she's in the private sector, where she is doing even better than what she did at AIMS. And because of her brilliance and her charisma, she has been awarded the Padma Shri Award by the President of India, and she holds numerous positions, and she's a very, very active person and a dear friend. Dr. Padma.
Thank you so much. Can I share my screen, please?
Yes, ma'am, please.
Yeah. So, can you all see this?
Yes, ma'am.
All right. So I think. So at the outset, thank you so much, Innova, for this. The opportunity to connect. It's an honor and it's a pleasure on the eve of Dhanteras. And Nashli, you've always been so very, sweet about it. And yes, it's nice to share the podium with a lot of close friends out here right now. So when we talk about, they started off with this pretty inflammatory topic about what's going wrong with IV thrombolysis in India. So, you're actually not starting with a huge amount of science out here, but actually with all the science that is backing us up, why aren't we performing to the optimum that is actually needed? And I guess, the bottom line here is that we are a huge nation and the stroke statistics are staggering. We have our challenges, which is a lot of them are similar across the entire world and some pretty unique to our own country. So when I talk about the statistics, this is like carrying coal to Newcastle. Uh, if I talk to the stroke guys who are, whether they're stroke neurologists or stroke physicians, well, what we've seen in the registries, which has been recorded, is that steadily the developing world is accumulating more stroke burden, more in terms of both in terms of numbers as well as the outcomes. So you have the incidence as well as the prevalence in the higher income countries, which we have shown a steady fall. That is true even for cognitive impairment. We have the Framingham registry, which is showing that even cognitive disorders, there is a kind of a fall. And all the developing world, there is a steady increase. So there is an issue that something is not right in terms of preventing this. And our own stroke registry programs, I was a part of this program as well, which is by the ICMR. And the population, the based stroke registries, and now we have hospital based stroke registries, which are I think still ongoing. But this was sort of quite a revelation. I was sort of, an ombudsman trying to monitor what was happening in Kachar and Varanasi. And then you had this wide variations in terms of accumulative risk and the outcomes and how the MRIs were being done and so on and so forth. But overall, it's been said that, the pooled sort of, if you look at in the stroke surveillance system, what is happening, the data, the risk of stroke was 1 in 10 amongst the male and 1 in 15 in women. Accumulative thing, and there were a lot of lacunae as to how, when how it is when you look at a registry and who's getting the data, how is it being analyzed, and then you're taking a sample and not exactly is the sample enough and so on and so forth. But then this was a great way forward, and this is a published registry we have. We also looked at the stroke epidemiology studies, and this had spanned across almost a couple of decades. And in that, we found the distribution of stroke subtypes in terms of hemorrhagic and ischemic, not the stroke subtypes in terms of what is in the ischemic. And then you do have that coming towards the eastern side of the country, you have the belts, which are more hemorrhagic. So the stroke belts in the east and far east, you have a lot more bleeds. And this has been documented not just in the Calcutta registries, and also in some of the Assamese, from Guwahati. So in the northeast and the east, you have more bleeds happening. And that's important to us in terms of preventing and why are there more bleeds in this part of the world. The disability and fatality rates were pretty, humbling in terms of how our care is transforming to the outcome of these patients. And post-stroke disability at 28 days, we have the published data that they are pretty bad. You have almost nearly 50% who's severe. And in the community versus in the hospital, this was a Mumbai and the Bangalore registries, you found that the case fatality rates is nothing which seem to be, we could be proud of. There's a whole big room for improvement. And then when you're looking at the status as you can see about the uniformity of stroke education, there were few studies, and in that we've seen that even when you're looking at a general population and how they're aware of it, although this is not a published data, I'm quoting just out of our experience, even in District Hospital of Leh. We've been holding that the clinics in that is Leh, Ladakh, and it's just not, it's not 12.8%. Rajasthan seems to be much more literate. There, almost 60% would believe that the stroke never occurred in the brain. And also, what is causing the strokes would 30 to almost 20 to 30 something coming from an evil spirit. So you have, in spite of education, there is a percentage who still believe that which is the organ which is involved, and you would talk about everything except the brain. And we still have even our press who would say, heart stroke and a brain stroke. I mean, there's no stroke in the heart, but that's how even the headlines go. And in between the regional differences, there is a big rural-urban divide as well. That when you're looking at the population densities, you have, uh, the healthcare delivery system in India is, three-tier. You have a primary, secondary, and tertiary care. So you'll have 70% of the tertiary care, which is in the metros, and you have 70% of the care that has to be given by the private sector. 30% is the public sector. And in a large parts of the country, you do not have a dialogue between the public and private sector. So there are a lot of issues. In the Ludhiana stroke registry from northern India, they did find there is a difference in urban and rural population in terms of the risk factors. And then the facilities, obviously, I mean, this is a no-brainer. You will have more facilities and they're cluttered in the large metropolitan cities. And this three-tier system is what I was talking to you about. And the medical colleges, I mean, this was an initiative by Dr. Rohit Bhatia when he, got the impetus program from the ISMR as a huge vertical to get a uniformity in the stroke education involving medical colleges. And they have actually, taken out a lot of gaps in understanding. When you do not have an education also which is uniform, there is a problem. And in the healthcare delivery, the private healthcare for its sustenance would obviously be high cost. And the big elephant in this whole healthcare delivery system in India is the economics. And you tend to sort of ignore the elephant sort of vanishes. It cannot be. Whenever you're looking at any policy and any implementation, factor in the economics. And I'm telling you this sort of even a personal experience here. When Ayushman came in, Ayushman version 1 didn't have neurology as a separate column. And that was a time when I saw it, I ran to, Professor Paul's place because he was just my neighbor in Ames. And I said, sir, neurology doesn't figure. And then came Ayushman 2. And even in Ayushman 2, somehow the stroke was not factored into neurology. It was factored under general medicine. And it was 1,500 rupees per day for 10 days. And then you have to take some, I mean, it didn't factor in the cost of thrombolysis. It didn't factor in the cost of PVTs. And the version 3 does have provision, which is a way forward, but then there is a whole room for improvement again. So you need to factor in economics into this entire, when you're talking about make people aware that there is stroke. The poor guy is aware and he lands up in the emergency, and then it is the pocket which actually dictates what care he does. So that's another big limitation we have. And then the workforce. Well, we do have, it's not 2,300. Now we are better. We are around 3,500 neurologists for 1.4 billion population, and we would be definitely holding on. We'll add on another Australia in the next couple of decades. But that's not the point. The point is not how many doctors. That stroke is a stroke team delivery. It's not a single person. You don't necessarily need a neurologist. You need a physician who's a first contact person for any emergency. And that concept, fortunately, has now percolated down in the healthcare system. So I'm glad that thing, and it is driven by a lot of people. Nashli is out there with, when we have developed these stroke wheels, hub and spoke models, get physicians who are involved in emergency care also to deliver the stroke care. So I do think that getting the emergency physicians into the umbrella of delivering an emergency stroke care makes sense. We may not have a dedicated program for physicians like 2 years or a year, which is there in the European countries or in the UK. We can always have, and we are known for our jugaad, so we can do that. So the accessibility, availability, and affordability, I think, is the basic crux. Whenever you talk about a particular modality of a care, and how is your policy getting implemented, and how is it going to be that where is that last mile, and how are you going to reach out to the last mile, to the interiors of the Timbuktu of this country, irrespective of the economic, geographic, and social barriers. I think that's the challenge when we talk about science and the delivery of that science to a practical reality at the ground level. Now, when you're looking at thrombolysis, therefore, with all this background that we have about a healthcare delivery system, whether It's an acute stroke, it's an acute MI. By the way, ladies and gentlemen, MI is being treated a little more aggressively and better probably because of the tele part of the MI is more organized, and you also have a better dialogues between private and public. There's a big partnerships out there. And that's what I guess should also get into the stroke care. So it is underutilized. And then considering the number who need thrombolysis to number who get it. Now, thrombolysis is not the be all or end all of a stroke system of care. In the stroke chain of survival, you do have prevention, primary, you have secondary, you have rehab, you have all that. And the stroke unit is a big vertical which is unglamorized but makes a huge difference. But then when you're looking at thrombolysis, you're basically, the thing is that the awareness makes a patient come to you early enough to be able to avail that opportunity. And even if he's not a candidate, he still gets into the early stroke care system, including the stroke unit care. And that's a huge difference in an outcome. But then when you're looking at a policy and then you're going with your package and say, look, I need this to be able to better the stroke care in my country. How do you going to, really impress upon the policymakers? You need to have that drug. And I did that. In April 2013, when I went to the ministry and said, look, there is this thrombolysis program. In 1995, you have this drug approved. Let's get that on board. And there in the central ministry, the question was, okay, in MI, you have a drug which can declot a clogged artery. Do you have anything like that for a stroke? And then I realized how much there is a gap of that, the science to percolate down to the policymakers. So we said, no, we also have that. But at that time, it was 3 hours. Now there you have 6 hours. We just have 3 hours. They need to know it. And we need to have this drug on the shelf to be able to deliver it. You need to get that going. So when we say that there is a kind of a magic bullet out there, if I give it in time, it has a huge tangible results in terms of bettering, in terms of disability as well as mortality reduction, then that drives home the packet, the point to the policymakers that, okay, you have this, you have a science backing it, so I'll get the policy in place. So in the Indo-US registry, which is obviously hospital-based, we were part of it, about 11.5% did. I mean, that's huge. So in the best of centers, you compare it in the world, in Calgary, it is 33%. So 1 in 3 do. Now, maybe you're not going to get this in big tertiary. This is relegated to big tertiary centers, but we can better. It cannot be 0.5%. We need to get it up to at least 10 times, So, and then China, I believe every patient is admitted. I may not have that luxury because one, there would be a limitation of number of beds. But the other is, again, come back, elephant. There is economics, which also has to be, done. And then we also have about stroke ready centers. Now, those are the ones which are capable of IVT. I'm not talking of comprehensive stroke centers, which would also have an EVT, which will have a neurosurgeon out there. You have the entire stroke chain, people ready to help. But at least when you have an IVT, means you have a plain CT and you have an IVT capability that makes a stroke ready center. And the estimated 100, maybe a little more than that, still it's not going to be sufficient to be able to deliver a stroke care because strokes are happening across the country, even to the most interior parts. So the time which is lost in transport, time which is lost in not having a stroke map apps to, even if you do pick up a patient, where is that stroke ready center where I can immediately get that treatment and not get waylaid by a center which does not have a CT, does not have a thrombolysis, does not know what to do with it. Your time is lost. So that is an important thing. And the cost of medications is an important factor. I've been telling that, but in that, I guess there has been a progress. At least we now have genetic place. I'm very, very proud to say that India was the first country to get this. India was the first country to actually legitimize and give approval for the use of genetic place, and now the whole world is following. So the medication cost here definitely has got better. And I think even after the COVID, I guess this push and the cost factor has really helped in increase of thrombolysis rates in the country. So, these are all there, but I think in the stroke systems of care, in the continuum and in the stroke chain of survival, we do have disparities. So we've done this, Shailaja and all, we've done this geospatial distribution of what we call as what is a ratio of one comprehensive stroke center to, say, a 1 lakh population. And we are dismally low compared to the developed world, but that's okay. I mean, we're still getting there, we're still improving. But what was more important is there's a big north, south, west, east divide. South is doing very, very well. I mean, I think the north, northeast has a lot to catch up from what is being done in south. Madhya Bharat, the Midwest, not Midwest, the middle of India is also has a big problem. Whereas the West, thanks to Nashli and others, is doing well. North is reasonably okay. Dheeraj is sitting there. South, Vijaya, you're a torchbearer. South is doing extremely well, but the East has to catch up a lot. So this kind of a disparity, and the Northeast is probably almost non-existent. So now we have actually mapped out what are the gaps, what are those challenges, and measuring that is absolutely essential. Unless you measure, how will you improve? And in the stroke care units, and that's again, I said, looks very unglamorous, but by definition, you have this very specialized system, specialized personnel who would preempt and prevent and treat a stroke complication. Simply put in, so it is a geographically, defined area, and the specialized set of people. So it is not again rocket science. So taking this as a model, it is probably better that it is easier to have a lot of stroke units, and that still is a work in progress. So in this stroke chain of survival, whether, as I said, primary to secondary prevention and whole of it happening in the middle, all of us know the science and all of us are aware what to do it. But when it comes to brass tacks and at a ground level, there are a lot of challenges wherein we have to bring in lot many specialities, which includes emergency, go beyond medicine, get a transport system, not just Ministry of Health and Family Affairs. We have to get a lot of other ministries involved and a whole lot of those things there. Yes, hub and spoke model is a great thing to go because it has brought in telestroke. And we have, in fact, there's a telestroke which was first established in Himachal in April 2014. I'm not very sure what's happening at this point of time, but that is a great thing because the first thrombolysis there was done by an orthopedician, and I think that actually, and it's a published data, and the world recognized it. Then we have Nashli, who had been driving this hub and spoke model in the West, and also 2018 Save the Brain initiative. Now, as far as the EVT is concerned, because now we are bringing in the critical corpus of neurointerventionalists thanks to a NEET program, thanks to the National Board of Examination, and thanks to a revised DAME curriculum, because I was actually the one who revised it, got it up there in 2023. God knows whether it's being implemented. I'm out of that system now, but I hope it does change. But then we are having a lot of those people who are trained and can do the interventional, that is for stroke interventions. But still, again, a large room for improvement, a long way to go. The telestrokes are there, and then telestroke, I think, is definitely, it's not, can we do it? It has to be done. It's a necessity. And that, especially when you have to bridge across expertise, the distances, as well as everything else thrown in the middle, and also the cost factor. And I think telestroke has to be there. Now we brought out the telestroke guidelines. I was one of the authors for telestroke guidelines. We brought out in 2023 again in the last part. And so this Himachal, yes, we did publish this 150 patients, but again, the sustenance and also scalability. Now that's something which you bring in with a lot of fervor, and then it doesn't sustain or it doesn't scale up to a level which is required. Then it's not doing its job. So you need to do all that, and I think these are the things which is these are the challenges for the younger lot to take up, because each part of it, getting the patient right time to right place with the right imaging and right drug, each one of this is a challenge because a lot of things, even just a week ago when we were discussing another symposium, stroke symposium, I said, what is the best modality? Now the world is divided between MR and CT imaging. For me, workhorse, plain CT. At a district level, plain CT. No bleed, no big infarct. Just get your blood pressure and the blood sugar and you're good to go. So you need to have those kind of monkey-proof guidelines to be able to cater to the last mile. I'm not talking about a comprehensive stroke center. For thrombolysis, you
Padma,
actually need stroke clinic.
could you
I'm
wipe?
done. I'm done. Thank you.
Oh, thank you. Oh, wonderful talk. And you know what you said about the stroke unit, it's fantastic what the stroke unit can do, you know. So it's not a general ICU. It's you know, all our patients were being dumped in the general ICU, and let me tell you, with the stroke unit the outcomes have improved dramatically. So, and it's very easy to set up. It's not so difficult. You just have to have a small place, maybe 6 beds. Ours is 10 beds, and it does a tremendous amount of good to many patients, even, you know, after thrombolysis, after thrombectomy. So we've been able to help and save so many patients because of a dedicated stroke unit or a neuro ICU. And somehow this telestroke doesn't seem to have caught on so much, you know, though we want it to desperately, but somehow it's not catching on so much. I don't know why, because, you know, now we have such good telecom systems and all, so somehow it's not catching up. I don't know what you feel, Padma.
No, it's not. It's not the question of catching up, Nashli. What happens is, like, we want, when we first got the Himachal, then the other state I went in was Rajasthan and Uttar Pradesh. And April 14 and April 2015 and 16, Uttar Pradesh has 72 districts. The thing is that when you bring in only public sector, and then you land up a emergency person who's looking at a care of somebody who's sick in a district hospital, the guy is already has an MI, has a maternal child health, has a trauma, has all other emergencies, he's a snake bite, he's got poisoning, what have you, and you dump an acute stroke also on him. What is the incentive, Nashli? So you had to actually look at it. I mean, it's not just a specialist that that guy connects with me. We did that. We had Rai Bareli and we had Agra, who were, there's a certain amount of altruism, some certain amount of aptitude. Okay, I need to do this. They would do it. But can you bank only on that? I think we should get in incentive programs. That is the reason I believe that the public-private partnerships will make something which is viable and sustainable for someone to move across and do an extra mile. Thrombolysis is an extra mile, Nashli. You have to get up at 12 o'clock midnight, take a decision and do it, and account for whatever the responsibility it is. It's important there. And for that thing, if it is just thrust upon it as your duty, it doesn't. So I do believe that for this kind of a delivery system, we need integration of different verticals of how this delivery is being done. Then it will sustain, because it's a win-win situation for everybody. I think, Nashli, you should head that committee and get those algorithms done.
You know, see, we have to transfer our passion to the periphery somehow. We are not able to transfer that passion, and I think also money is involved. You know, if there has to be some financial incentive, otherwise it's not happening. It's not happening at the rate we want it to. Anyway, we'll take this question later. Raunak, we'll get Dr. Subhash Kaul. Yeah. What can I say about Subhash Kaul? He is the ringleader. He is the torch bearer. He is the trailblazer. He's everything. He's Mr. Stroke of India, and of course, all these things are there. You can read them. You know, orations and this and that, and many awards and many things. But the man is amazing. He's a very dear friend, and he is passionate about stroke. So we'll hear from him today. Subhash, you're on mute.
Thank you, Nashli.
Yes.
And I think you can remove this slide so that I can share my screen.
Yes, sir.
Just give me a second. Badhiya.
Good morning. Good.
Okay.
Yes, sir. Slides are visible.
So yes. Yes. Okay. Thank you very much. It's really wonderful to be with all the friends this evening. And acute ischemic stroke is very common. One stroke case every 40 seconds in our country, one stroke death every 4 minutes. And if we have to give IV thrombolysis to dissolve the clot, the window is 4.5 hours. But then our aim should not be 4.5 hours. Our aim should be as early as possible. We should be able to thrombolyze the moment stroke occurs. 1 hour is better than 2 hours, and 2 hours is better than at 3 hours. That's why the concept of golden hour. And there's huge data and papers to support that. There are papers which have shown the outcome of thrombolyzing in the first hour and thrombolyzing at the second hour. And there's huge difference. So therefore, we need to...
Put on full screen, the slides.
Yes. Yes, we'll go to the full screen, sir. Okay. Now, unfortunately, many people come late to the doctor because their relatives, the onlookers, don't suspect stroke, or they waste time is going to general physicians and small hospitals. So the first thing in this chain to improve stroke care is to be aware of the stroke symptoms. And there is this very good eponym, which is now very well known to many people, is called... where is my slides? Where's my... Yeah. Ronak?
Yes, sir.
Can you see my screen?
Yes, sir. We can see your screen. So do you want me to share the screen?
No. I already had. No, I was just showing it where it is gone. Did you do something?
No, sir. It must have got minimized. Can you just try again? Or sir, do you want? You can just reshare. I'll just stop your sharing, and you can try resharing once again.
Yes, I think let us do that. I'll stop from
Stop
there.
sharing. Please try again.
Yes, I think it came when I did a show. Now, can you see this?
Yes, we can just put it on full screen mode, sir. Then we can...
Yeah.
Yes, I think it is full screen now.
Yes, sir.
Yes.
And everybody knows, everybody knows this be fast slide, that whenever a person sees anybody losing his balance suddenly, or having any visual disturbances like double vision or blurring of vision, or the face getting drooped, or the arms not working properly, or speech getting garbled, the onlookers and the people around it have to think that it can be a stroke and immediately shift it. Now, this is not for doctors. It may be for general care physicians and all, but it's basically for public. It's basically for the ambulance drivers, that they have to suspect that this can be a stroke. This is the basic identification. And why it's important is because the patient has to be thrombolyzed within the golden hour, for the simple reason that a person who's having a stroke is like a house on fire. Every second the house keeps on burning, and if you waste a lot of time, the whole building will be burned to ashes, and after that there is no point of extinguishing it. Every second 32,000 neurons are lost, and if the stroke is big enough, almost huge billions of neurons are lost. So therefore there's a need to thrombolyze not just within 4.5 hours, but as soon as possible. Now, rapid neurological assessment after any doctor or physician sees means that patient, the proper history should be taken. Most important thing in history is when did it actually start, right? You have to take sometimes history from the relative, sometimes from the patient himself, or sometimes from the other people who may be knowing. It's very important because your whole timing depends on within how much of time you are thrombolizing the patient. And then, of course, the risk factors. And then there is no need to do any extensive localization and waste time on it. A gross localization is enough. And one must know NIHS scores, because by that you can able to measure the damage or the neurological deficits which the patient is having. So the idea is that a rapid neurological examination in a suspected stroke should not take more than 5 to 7 minutes. Okay. Now, the aim of this initial evaluation is to distinguish stroke from other stroke mimics like hypoglycemia or abscess or demyelination disease, and also to make sure whether it's a hemorrhage or ischemia, which comes only from imaging, and to know what could be the likely etiology of the stroke, whether it's a cardioembolic or whether it's any other etiology, and then to plan the treatment according to that. And if there are some red flags, one has to make sure that it's indeed a stroke and not anything else. For instance, if a stroke happens in young, to make sure that it's indeed a stroke. Similarly, if the patient is in deep coma, we have to make sure that we are not dealing with any other diagnosis, because many times they can look like stroke, but if you go deeper, there may be an alternative pathology. Or if the history is not sure. Many times I have seen people bringing to hospital saying that it has happened within 3 hours, where actually it has happened within 3 days. So therefore, history, the proper history is very important. Now, the initial management is initially to stabilize the patient. Whatever is the etiology, patient should be stabilized. The ABC is very important. That means his airway should be all right. There may be a need for intubation. His blood pressure should be all right. He should not be extremely hypotensive or extremely hypertensive. That's very important. And then we should plan the patient for further evaluation, to confirm the diagnosis of stroke and to think whether any specific treatment like thrombolysis is required. And since we are talking of the golden hour, the main challenge is to give the thrombolysis to patient, if he is qualifying for it, as soon as possible. And internationally, door to needle time, which involves the patient going to the neurologist and getting a CT scan, then involving all that, the moment the patient enters the hospital to the moment the drug actually enters his veins should be less than 60 minutes. And I must tell you, everybody, that in our country, I think Dr. Nasli Chapuria has established a record. I think in his hospital, the door to needle time is just 20 minutes, which is 1/3 of what is internationally recommended door to needle times. And this is where the whole game is, that how efficient is our stroke system of care, because that is what finally matters. Now, the CT scan is the very easily available thing. And the most important thing in CT scan is it should be normal. It should not show any other pathology like a brain abscess or a massive brain hemorrhage or any other etiology. CT scan usually in the first 6 hours is normal, or it may sometimes show a mild hypodensity. But we must carefully look for hemorrhage. Even the smallest of the hemorrhage is a contraindication. And that is the main contraindication. There are others also, but this is the main contraindication. And Dr. Padma, many years, I think 20 years ago, published showing that there is no need of doing any hematological workup and platelet count and all that thing. Even though we should not give in people who are having less than 1 lakh platelets, yet there is no need to do it. If you come to know by any chance, that's a different thing. But there's no need to do any workup except blood glucose. So you just have a clinical suspicion, a CT scan, blood sugar, and that's it. Now, what are the options if our patient qualifies for thrombolytics? We'll also go to the qualification criteria, but if he qualifies for thrombolytics, what are those? One is alteplase or RTPA, which we have been using for the last more than 2 decades. And the other one is the tenecteplase, which is the newer one and the better one. Now, both of them, the window is less than 4.5 hours, but it doesn't mean we have to wait for 4.5 hours, which I'm repeatedly saying, because the earlier, the better. And the other new thing in the last few years has come that all these patients where we are giving intravenous thrombolysis, we should also do their vascular imaging to make sure whether there's any large vessel occlusion. Because if there's a large vessel occlusion, then we have to give them mechanical thrombectomy. We have to pull out the clot, and that can be done up to 24 hours, depending upon their qualification. Everybody may not qualify for it, but some patients who still have good collaterals and who have got small cores, they can be mechanically thrombolized even up to 24 hours. Now, what are the eligibility criteria for treatment with IV thrombolysis? One is that it should be a clinical diagnosis of ischemic stroke. Now, this point is very important to know. You don't need a radiological proof of ischemic stroke. For instance, if you have got a clear-cut, acute onset brainstem syndrome and your MRI may be completely normal, you can still go ahead and thrombolyze these patients. You don't have to prove a stroke on the radiology. You have to only rule out hemorrhage. The diagnosis is clinical, and it's very clearly said here. And the onset should be less than 4.5 hours. And if the exact onset is not known, then we take it as the last time when the patient was seen to be normal. And age, as per the trial, is less than, it should be more than 18 years. But in the real practice, people after the age of 12 are also thought to be almost like adults. So after taking the consent, we can even thrombolyze from the age of 12 onwards. Now, these are the exclusion criteria, and it's very important to be aware of them. One is that if there is a ischemic stroke or a severe head trauma in the preceding 3 months, because this can cause hemorrhage in this patient because of their friable brain, soft brain. If there's a previous intracranial hemorrhage, hypertensive intracranial hemorrhage at any time in their life, but if it's a post-traumatic hemorrhage, which has happened more than a couple of years ago, then we can go. If there's an intra-axial intracranial neoplasm, like a glioma, it's a contraindication. GI malignancy is a contraindication. GI hemorrhage in the previous 21 days is a contraindication. Intracranial or intraspinal surgery within prior 3 months is a contraindication. I know there are some very brave neurologists, they say we'll get over these contraindications also, but it is better to have discretion as better part of valor, and in these be very careful and if possible avoid. Then there is a general exclusion criteria, hematological, like platelet count less than 1 lakh. If you already know about it, then better not to do it. Many times people don't know about it and patients have less platelet count. They have given patient has not had a bleed, but that's not the reason to thrombolyze, because the mishap happens once in 100 and that can create a problem. Similarly, if the patient has he's on anticoagulant like warfarin and INR is more than 1.7, we should not thrombolyze these patients. APTT, if it's more than 40 seconds, you should not, but if it is less than 40 seconds, you can go ahead and thrombolyze. And you will find this situation mainly in dialysis patients, because they get heparin and all, and they get suddenly a stroke. Just check their APTT. If it is 39, and even if it is 40, you can thrombolyze this patient. And if the patient has been receiving low molecular weight heparin regularly for the last few days, then we should not thrombolyze them. 1 dose is okay, it doesn't matter. And patients who are on direct thrombin inhibitors, these days many patients are on apixaban and rivaroxaban and all. The conventional exclusion is that if they have received a dose within 48 hours, then probably we should avoid it. If patient is having a suspected subarachnoid hemorrhage or a proven subarachnoid hemorrhage, obviously a contraindication. If the blood pressure is more than 185 systolic or 110 diastolic, and if we are not able to lower it, even with 2 doses of labetalol or even any other strong agent, if we are not able to easily lower it, better not to take the risk of giving thrombolysis. Active internal bleeding obviously is a contraindication. Infective endocarditis should always be ruled out. I have myself seen disasters. Even their over-enthusiasm, I have seen doctors thrombolizing the patients and then patient having massive aneurysmal bleeds in their brain because they missed the fever in the stroke patient and they failed to auscultate the heart. Infective endocarditis still is occurring. So therefore, this is one indication which you must always be very careful not to miss infective endocarditis. And carotid dissection is not a contraindication, but aortic dissection is a contraindication. So therefore, the question is that whenever we are doing thrombolysis, it's okay to be over-enthusiastic, but we have to be over-enthusiastic and alert so that we do not miss any one of these contraindications which can put us in soup. Now, calculate the dose of the alteplase. You have to, for alteplase, you give 0.9 milligram per kg body weight. But for tenecteplase, it's 0.2 milligram per kg body weight. I am giving even 0.25 milligram per kg body weight, documenting it on the case sheet, explain to patient, because that's the dose which has been internationally shown to work, and that is the better dose. And patient should be admitted in the intensive care or a stroke unit. And every hourly his blood pressure should be checked. These days we have got continuous BP pressure monitoring systems, so there is no need to actually stand there, but we should be aware that how much is the blood pressure. Many of our patients, internationally also, those who had the bleed, at some point there was some carelessness on the part of the nurse or the resident, and that bleed coincided with a surge in the blood pressure. So this is a reality, that every half an hour, every hourly, a check should be kept on the blood pressure, and if it's going high, it should be immediately lowered. And after thrombolysis for 24 hours, patient should be observed. And during this time, aspirin also should not be given. It's given only after 24 hours. As far as possible, one should avoid any invasive procedure, including even a nasogastric tube, unless it's very much required. Even a catheter should not be placed. But sometimes there are situations where there is no way. In those cases, you can go ahead and do that, but avoid as far as possible any invasion. But it is not applicable to drawing blood and all. I remember one of my patients who had a diabetes, and next day when I came for the rounds, I found sugar to be 440. And I asked that why you did not give him any insulin. They said the instructions were there, don't give any catheter, don't give any injection. That's why we didn't. So it should not be. The doctor himself should really go and monitor everything. Some things are allowed and some things have to be done. Now, one of the aims of this post 24 hours care of the thrombolysis is to see whether patient develops any bleed. If the patient does not have any new sign or symptom, then we can repeat the CT scan after 24 hours. But if within these 24 hours after thrombolysis, he complains of headache or there's increase in the deficit, then we must repeat his CT scan before, even at 12 hours. And you can have various grades of hemorrhage in it. If it's a mild hemorrhage, like a petechial hemorrhage or little more than petechial hemorrhage, we don't have to do anything, closely observe the patient. But if it becomes more than that, it's called pH1 or pH2, which you can see here in the lower slides, then in that case, we have to give him cryoprecipitate, which is concentrated factor 8, and we can monitor it along with the serum fibrinogen. We should immediately send the serum fibrinogen, and before the level comes, we should push in one unit of cryoprecipitate, and then give further cryoprecipitate based on whatever results we get from the fibrinogen. We want to bring it to 150. We can also use tranexamic acid, 1000 milligrams IV, if the quantum of bleed is more. And now, the last thing is which one we should use, tenecteplase or alteplase. Well, I think everybody these days, those who thrombolyze, know that tenecteplase has several advantages over alteplase. It is more fibrin specific, therefore it will locally act on the clot itself. It is 3 times or even more potent than alteplase in dissolving the clot. And there is not much resistance to its use, unlike alteplase. And for fibrinogen deficients, also effective. And its plasma half-life is more than that of alteplase, so it works for much more time because it stays in the blood for much more time. And the most important practical advantage is that we have to give only single bolus. You just give it and that's it. And even if you have to ship the patient to a different center, you can do it immediately. Whereas here, in this case of alteplase, you have to wait for 60 minutes and then observe the patient and then shift. So therefore, this bolus thing is really a big advantage in favor of tenecteplase. And there is a lot of clinical evidence also in favor of this. There are 5 head-to-head randomized controlled trials between TPA and tenecteplase. And all of you have read those, ATTEST trial, NORTEST trial, EXTEND. There are subtle differences between these trials, but overall, they are showing that tenecteplase is as good as alteplase, and in certain situations, it may be even slightly better, which has even now come into the guidelines. For instance, people where you document a large vessel occlusion, and these days it's mandatory to do the vessel imaging to make sure that we are not missing any large vessel occlusion. And if there's a large vessel occlusion, then definitely tenecteplase is better as far as the ultimate outcome, even after mechanical thrombectomy is concerned. So in AHA guidelines, ASA guidelines, Europe, India, China, all guidelines are supporting now tenecteplase. It has come in Canadian guidelines and European guidelines. So short preparation of tenecteplase and administration time is advantage. No requirement of second intravenous line. And the most important thing in our country is the lower cost per dose. I think to begin with, the cost was less than half, and it may even get even lower than that. And that is in our setting a very, very important. That's why most of the governments have now brought tenecteplase in their system, and it achieves faster thrombolysis, and the unfavorable outcomes are almost similar to that of the TPA. So in conclusion, most important thing is to recognize stroke. It's a time-bound, time-intensive medical emergency, and this recognition is very important for general public, for general doctors, because stroke can happen to anybody at any place and any time. Until the entire population is aware of it, our battle is incomplete. And recognition of these symptoms and evaluation is the first important step, and to refer the patients to a hospital. And assessment by the NIHS scale is important, and not a very detailed neurological examination, just gross neurological examination, which should not take more than 3 to 5 minutes. And the CT scan is freely available in all the districts these days. That is the most important initial investigation. IV thrombolysis within golden hour in eligible patients, and preferably with tenecteplase, is definitely associated with improved outcomes. And thank you very much.
Nice. Nice summary.
Yeah, Dr. Gilvas, could you comment? Dr. Gilvas? Yeah, wonderful
Dr.
talk.
Nestle, you can comment.
Yeah,
You can comment.
Subhash. Actually, after tenecteplase has come, the amount of stroke thrombolysis has skyrocketed. It has doubled or tripled, and it's gone right into the taluka place, and even in the district places, of course, but even into the taluka place. So somehow it has caught on very well, even in the periphery. Of course, still there is a huge treatment gap. We are not saying that the treatment gap is bridged by any stretch of imagination, but we are getting there. And many physicians are able to do it. And, these trials which were done for tenecteplase, they were done for non-inferiority. They were not done for superiority. So we really, all the trials were for non-inferiority. So if we do a trial for superiority, I don't know, it may show that it is superior. And as you said, in some instances it is superior, which I fully agree with. And of course, the ease of administration and the cost, because it's a biosimilar. I think these are big advantages of tenecteplase. So thank you, Subhash, once again for
Thank you, sir.
very,
Thank
very
you, Nestle.
talk.
Thank you, Nestle. Yeah.
Dr. Nasli, can I have one comment?
Yes.
With your permission? Yeah.
Yeah.
And so actually, this is where the ISA, Indian Stroke Association, has taken the initiative. Of course, Genova is our knowledge partner. We are doing this CMEs across India, as you have seen, starting from Raipur. We have covered several places, and we are going to do more. Starting from last year, we are doing this initiative. It has really helped taking this thrombolysis to peripheries, and the physicians and emergency physicians have become a part of our team as well. Just for the information.
Yes, Vijay, that is very true, and I'm very glad that it is a knowledge partner. And also, some of us are doing that no thrombosis program.
Yes.
And it's a big hit. It's a big hit with the physicians. And
True,
sometimes, 300 and 400 physicians are attending this program. So,
Yes.
this knowledge is spreading far and wide. And many congratulations to this entire team for doing this. And it shows the numbers have gone to, I don't know how much, 40,000 per year. We were barely touching 9,000 patients in the whole of India. Now we are touching 40, 50,000. So it's a big jump, but still, as I said, a long way to go.
Right.
Yeah.
But ISA endorsing this physician and emergency physicians this year, we added them. It is hopefully it will have more fruitful results in the coming years.
See, if they can do for MI, why can't they do it for stroke thrombolysis?
Yeah. When we are interacting with the physicians, they were saying the hesitation
Absolutely.
about they were not comfortable. Once they
Yes.
know and we discuss out things, I think this will help. Okay,
Yes.
thank you.
I
Thank
think,
you. Thank you,
yeah,
Meenakshi.
Vijay,
Thank you.
Nasli. Hello, Nasli.
Yes.
We were talking about this telemedicine, which you, I mean, coming from your previous comment, which you said that the telemedicine has not taken up. I think telemedicine will not take up if we depend completely on government for this. But I think between ourselves, telemedicine is helping a lot.
Yes.
I'm sure many of the physicians must be contacting you through video call, showing you the. I mean, that's also telemedicine.
Yes,
so I think
yes, yes.
between ourselves, it has a huge, and we are also using it. I'm sure so
We are
many
using it
doctors
in
must
our
be.
hospital.
Yes,
See, every
yes.
time I cannot be on the patient's
Yes.
bedside. It is impossible. Nobody can.
Yes, yes.
So we are using it on a day-to-day basis. Yeah.
దీంట్లో ఉన్నాను అనేసి
So
Yes,
the
Mr.
informal telemedicine, I think, is working superbly well.
Yes, yes,
Yes.
yes, yes, yes.
Yes.
Okay.
Thanks for
Thank
that
you.
correction. Thanks.
Yes, yes, yes.
Dr. Gilbas, can you introduce Dr. Meenakshi? Anyway, I think we have
Yeah.
lost him. So Meenakshi is a very, very dear friend, and he's super enthusiastic. He's a Nimant alumni, and I think we talk almost every day on many, many things. And he's really extremely innovative, and he's come out with very new concepts. And I'm sure that he's going to enlighten you and give you a lot of information in his talks. So thank you, Meenakshi, and kindly do your talk.
Thank you very much, sir. Can I share my slides?
Yes, sir. Please try sharing now.
Are my slides visible, sir?
Yes, yes.
Put it on full screen mode. Yes, sir. Please
Thank
go
you
ahead.
very much. Sorry, can I go ahead?
Yes,
There
sir.
is
Please
some
go
sound
ahead.
which is coming. Some mobile phone ringing sound is coming. It's not from, yeah. Right.
Please go ahead, sir.
Thank you very much, MCure, for bringing me to this platform and share my thoughts amongst these experts of stroke all across the country. So where do we stand in terms of tenecteplase from, TPA? Tenecteplase is produced by recombinant DNA technology using Chinese hamster ovary cell line. So the key question to ask is how many mutations the complementary DNA has to undergo for natural TPA to be subjected to produce TNK. So there are three things which has to be done, which involves three domains, the Kringle 1, Kringle 2, and the protease domains. And what does it do? These modifications in Kringle 1 and Kringle 2, the first and second modifications, they prolong the elimination half-life. And the modification in the protease domain, it augments the resistance to plasminogen activator inhibitor, and it augments the fibrin specificity. Net effect is that the three mutations result in prolongation of the half-life of approximately 18 minutes, higher resistance to plasminogen activator inhibitor, a whopping 80 times, and higher fibrin specificity. The net benefits are that the molecule acts for a longer time and has got lesser systemic side effects. So what is the rationale for taking up this iris TNK's data? Tenecteplase was approved in India at a dose of 0.2 milligram per kg body weight for acute ischemic stroke, the window being 4.5 hours. The real world data is however limited, and the registry was mandated by Indian regulators for at least 1,000 patients. And this data on iris TNK bridges the evidence gap between the trial and real life use. So what is the trial that was conducted? Our own Indian data was a tenectase trial, and this was published in American Journal of Cardiovascular Drugs in 2018. It consisted of actually two parts. The first part is the dose finding study using two doses, 0.1 and 0.2 milligram per kg body weight, establishing that 0.2 milligram per kg body weight is the correct dose, and then going on with a confirmatory study and proving that this molecule was not only safe, it was also effective, leading to the approval by DCJ of the molecule tenectase for treating patients with acute ischemic stroke. And these were the key takeaways from this initial Tenecte's Indian study, it used historical controls from NINDS and showed that the primary outcome of this trial was improvement by a score of more than 4 points in NIHSS or reaching a score of 0 at 24 hours. It was comparable with Altiplase, though the absolute percentages, if you look at that, is more with Tenecteplase 58% vis-a-vis 47%. Then we look at the secondary outcomes, improvement reaching an MRS score, an excellent outcome of 0 to 1, a whooping 70% compared to 39% with NIMS data, a statistically significant difference was seen. And then what happens to the functional outcome in terms of Barthel index? Barthel index of 50 to 90, meaning a good functional outcome, was seen in 36% vis-a-vis 16% at 3 months. And again, this data was statistically significant. This is as far as the outcome is concerned. We also want to know not only the efficacy, but also the safety in terms of symptomatic intracerebral hemorrhage compared to Altiplase, which was responsible for 6.4% hemorrhage. Tenecteplase produced hemorrhages only 1.1% in this initial data. And the mortality was quite low, 17% with Altiplase versus 5.5%. All these safety data were overwhelming in favor of Tenecteplase with a statistically significant difference between the two molecules. So that led to the formation of the Tenectase registry, which was the Indian registry in ischemic stroke with Tenecteplase, the TNK-TPA, with about 1,015 patients over a period of 6 years between October 2017 and May 2023, finally getting published in 2024 in the Journal of American Heart Association, of which many of us were part of. So the objective of this Tenecteplase Indian registry were twofold. First is the safety data. That was a primary endpoint. And whether it is beneficial, that was a secondary endpoint. So the design was open label. It was a prospective data, multicentric, non-randomized, observational data. Patients received a standard dose of 0.2 milligram per kg body weight bolus over 5 to 10 seconds after screening them using standard eligibility, inclusion, and exclusion criteria. Patients were followed for 3 months, as I mentioned, for the primary and the secondary endpoints. So what were these? The primary endpoint was actually safety, which was measured by the symptomatic intracerebral hemorrhage occurring within 36 hours after being thrombolized. Symptomatic ICH was defined as an intracerebral hemorrhage which was seen 36 hours plus or minus 6 hours on a post-treatment scan, and that should have been associated with a neurological deterioration resulting in either an increase of 4 points on the NIH stroke scale or leading to death. The secondary outcomes were all efficacy based, which looked at MRS data of 0 to 2, which means the patient becomes functionally independent at day 7 or at the day of discharge, whichever was earlier, and then a 3-month data. An excellent outcome, meaning MRS score of 0 to 1 at the same timelines, and also the NIHSS improvement of more than 4 points at the first 24 hours or 7 days, whichever was earlier, or an excellent improvement in NIHSS defined as more than 8-point improvement in the same timeline. And what was the Barthel index at the end of 3 months? So around 2,094 patients were screened and 1,079 patients were excluded, and 1,015 were included, of which 38 patients were lost to follow-up at the end of 3 months. So the data produced was based on 977 patients who were analyzed. These were the baseline characteristics. Of interest is to see that 70% were men, and majority of the patients belonged to 62 years, which was much lower when compared to Altiplase registries, which showed an age of more than 70 years, around 73 years in the Altiplase registries. The baseline NIH score was divided into 3 segments. The mild NIHSS means less than 7, which was seen in 35%, moderate in 48%, and 16% had severe strokes as defined as an NIHSS of more than 15. The baseline demographic characteristics, 60% were hypertensive and 43% were diabetic, and the other risk factors were spread as was seen. The onset to treatment time in this patient was a mean of 148 minutes, and that was achieved in less than 3 hours in 72%. In around 4.5%, the patients were thrombolized beyond 4.5-hour window based on advanced imaging criteria. So these were the clinical outcomes. As I mentioned, there were two aspects of this. First was the safety outcome. As you can see, what was the symptomatic hemorrhage? This was seen in only 6 patients, meaning only 0.1%, overwhelmingly smart data. And then the asymptomatic hemorrhage was seen in an additional 1.3%. And when you look at the efficacy data, that was a short-term data. The safety said that 0.2 milligram per kg body weight antiplase is safe in routine practice. And then coming to the efficacy, at 24 hours, the improvement more than 4-point score or a score of 0 was achieved in 34%. At the end of 7 days, it was achieved in 56%. And then an excellent improvement, by which we say the improvement exceeds 8 points on the NHS stroke scale or it reaches 0. This was achieved at 24 hours in 16% and 26% in patients, 26% of patients at the end of 7 days. This tells that 56% achieved a reduction of NHS of more than 4 at the end of 7 days, which establishes the reperfusion benefit early when patients are treated with antiplase. And then what happens to the long-term efficacy? As you could see here, the functional independence, which means the MRS score of 0 to 2, was achieved in 75%, which is quite a good score. An excellent outcome was seen. That means the MRS only 0 to 1 was seen in 55%. And the functional recovery was seen as defined in Barthel index of at least 50, which was seen in a whooping 92%. The functional outcome distributed in terms of MRS, as I mentioned, was seen in more than 60%. And what was the functional outcome based on the initial NIHS stroke scale? When you look at that, when the NIH stroke scale was much less, the improvement was quite dramatic. And very importantly, even when the NIH stroke scale was much more, it was more than 15, 46% achieved functional independence at the end of 3 months, even in these patients who had severe strokes. So comparing with the Altiplase registry, we could see that the symptomatic intracranial hemorrhage was only 0.6% compared to Altiplase registries, which showed 2 to 6% of hemorrhage. The mortality was low, only 1%, and the 3-month MRS for iris TNK data was 55% as against Altiplase, which was 50%. There was no randomized control arm. Still, I would say the results were quite reassuring. What were the limitations of this? So the strengths of this was that it was a real world multi-center data, large data, regulatory mandated national scale data. The limitations were that there was no Altiplase comparator. Variable protocols were used, which means there was a variability related to the site that was involved. There could have been an observational bias. Some data was missing. Missing data was seen in the follow-up in 4%, and it was a non-randomized design. In summary, more than 1,000 real weight patients from Indian patients were available in this iris TNK data. A very low symptomatic intracranial hemorrhage, a very low mortality, and a very good outcome, which demonstrates the favorable safety and outcomes, which supports the broader use of antiplase in our country. The future directions could be a direct comparison, about which our moderator was already talking about, comparing the antiplase with antiplase in Indian RCTs, exploring the extended window beyond 4.5 hours, and imaging selection, advanced imaging selections, subgroup analysis using age and subtypes, and very, very importantly, looking at cost effectiveness data. So in summary, this was a real world data of 1,015 patients, which established IV thrombolysis with tenectase was safe and efficacious. The clinical implications are that it's quite safe when compared to Altiplase. And then the added advantage of the ease of administration as a bolus. The lower bleeding risk means it is suitable for smaller and rural centers, which was just now talked in the previous 2 studies. And it facilitates pre-hospital administration and promotes the hub and spoke thrombolysis networks, which was again spoken of in the previous one. Thank you very much for the opportunity, and happy forthcoming Diwali to all.
Thank you, SMS, for a lovely talk. What is your experience with TNK, your personal experience?
It's a remarkable drug to be used. The reason, as I mentioned, gone are the days when the emergency people were actually hesitant to use a drug. Now they have just a bolus. And secondly, it saves a lot of time for us. Earlier, I remember I used to sit in the emergency for a good 1 hour sitting and then doing all these things because we didn't have the luxury of EMR consultants way back in 2005 or 7 when we just started that program. But now we can just give a bolus and then decide upon further treatment aspects, which is a real advantage. We need not have to sit and keep on monitoring the patients, give it and then go away. And third, definitely it has reduced the cost. It has improved the confidence level amongst our people. So all these things I think are real good advantage which can replace them.
Sir, we also have Dr. Amit Saraf, who was part of the study. Sir, any comments from your end?
We thank Dr. SMS sir and others who have been, part of this study, and I think they are the champions. We make the drug and we provide it there to them, and it is their experience, which drives us. So thank you very much, sir, for your comments.
One point I want to raise, and I want opinion from all the experts here. I've found that large vessel occlusion, somehow TNK works much better. And, all the time we say that for M1 occlusion, we should do MT. But many times we have found that, with TNK, it opens up and we can save tremendous amount of resources. So this is my personal observation. And of course, the interventionists don't like what I say, and I've been saying this many times. So what do our other esteemed guys say? Yes, Dheeraj.
Hi. Well, you're right. Well, we have trial data to back that fact up because the TNK extend TNK data as well as the bridging data with TNK that's when the difference came in TPA versus TNK pre-thrombectomy. There's a high recanalization rate, definitely. But we still need to wait for our Indian data, which was ongoing, the reopen trial, and let's see what that showed. But in general, you're right. There is a greater tendency that we see TNK data recanalization. The only thing, one point I would like to reiterate here for everybody listening here is the dose. The TNK has evolved over the country, and you were asking the experience. So we've had variable experience, but I think the dose matters. And the original 0.2, which was started, we had a great experience. I'm going to say we had a lot of experience, but that didn't seem to be as effective. And 0.25 is what the current worldwide recommendation is. We should stick to that and use 0.25 per milligram per kg.
Yes, absolutely.
And doesn't make even most of the patients will fit into the 20 milligram or the other available tenecteplase.
Yes, Dr. Vijay.
Yeah. On that note, the LBO and tenectase without thrombectomy. We have this Chinese trial, I think it is Tempo 2, where they did not have access to the thrombectomy. They treated with TNK and then seemed to be better. So in our resource limited, our patient doesn't want or cannot go towards thrombectomy. We can at least give tenecteplase. That's point well taken. Absolutely. I think that's why I mentioned this then. And we may somehow make a registry or at least case reports.
Yes, I think we should make a registry on this point.
We can pool those patients, and all of us can have some experience together.
Yeah, Subhash? Subhash, your experience?
No, I resonate with all of you. Yeah.
Sir,
you
what? I need to ask, sir. We are all using 0.25 milligram per kg body weight, but what is the DCGA stand on it, and what is the ISA stand on it, sir? What is the legal this one behind it, sir? Backing. We all use 0.25. After the act, that all of us are using 0.25, but I would just like to have a comment on this.
Hello.
Yeah, so I cannot comment on the stand of the various associations on this, but since the worldwide data supports that, and in fact, informally speaking, I even had a word with the original scripter of the guidelines, Dr. Kameshwar, he said use 0.25. He himself said 0.2 is what was approved, but 0.25 is as good. I mean, that if that is the one which is showing, there is absolutely nothing which can stop you from even. I don't think there may be a level any legality involved. Very soon, I think what like we had I had come out with the ISA guidelines many years back for the stroke. I think they need to be updated now, and that can possibly address this issue.
Dheeraj?
Yeah, let's move on. Dr. Gilbas, are you around? You're very quiet.
He seems to be around.
Yeah, but he's not answering.
He may have gone to a different room.
Anyway, Dheeraj is an old friend, and he's a professor at PGI Chandigarh, and he's been a stroke pioneer for the last, how many, 25 years? And he's done an enormous amount of work in stroke, acute stroke care, TCD, carotid Doppler, etc. And he's trained a large number of students and published widely and traveled widely and spoken all over the world. Welcome, Dr. Dheeraj Khurana, and kindly let us hear your thoughts.
Thank you, and I'll just share my slides. Is my slide, are my slides visible?
Yeah.
Yes, sir.
Yeah.
Great. So primarily I've been asked to talk on secondary prevention, which is not easy to talk in 15 minutes because that's a very vast topic, which encompasses the various types of secondary prevention strategies. But I will like to focus chiefly on the most important part, which is the antiplatelets, because if I have to take up every aspect, it will just take the whole night, in fact, whole evening. So to start, we know the burden of stroke is huge in India, and we currently are ranging between various registries of the country, which have shown us that the stroke statistics are mind-boggling, and we have around 1.8 million, maybe big, larger than that currently as our population has increased. Per year, we are having these many strokes, which is more than double what happens in the US. So you can imagine the kind of resources which the West have and what we have. We've been discussing resource limited settings, and we have to deal with even double the burden with half the resources. Most of them are younger patients. That's one fact that all of our studies have shown, which is different from the West. A lot of patients are in the younger age group. And what is worst is in the future estimates, we are going to be possibly in the next possible. It was actually, if you looked at old data, it used to say by 2025, we are going to be the capital of stroke and diabetes. We're already in 2025, and we've already crossed the population of China. So we're actually close to the predictions. And most of these strokes are attributable to the risk factors, the modifiable risk factors. So that's the more important part of the secondary prevention. So the biggest burden is a recurrent stroke, and that's what the secondary prevention is all about, to prevent recurrent strokes. And the recurrent strokes are actually the worst thing which can happen after a stroke, and 1/3 of the strokes which happen are known to be recurrent strokes. They are much higher than the cardiac events. And if you look at data, basically the North American NOMAS data, which is a very old data, but still informs a lot to us about the stroke risks. If you look at the stroke risk versus the MI, there is, as following a stroke, in fact, the risk of the event of a stroke is way higher, and in a cumulative fashion too, it is way much higher than the MIs or a non-fatal MI. So if you look at the fatal strokes, non-fatal and the total strokes, it's huge, and it will keep on increasing. So this signifies the importance of preventing a stroke, how important to understand how do we reach the best strategy to prevent a stroke. And this slide clearly shows the risk is greatest following a stroke of that of another stroke and not MI. Multiple antiplatelet trials. So despite antiplatelets, the number of strokes which happened in these trials, of course, this did not address various issues of other kind of uh, risk preventions, but strokes were still the highest. MI was not. Multiple trials have shown that. Now, whenever we get a stroke, there is a certain algorithm we all follow. It's almost everybody of us have a similar kind of a algorithm we follow, but it's some things are very straightforward. You will get a scan done to see whether there is a stroke seen, and if you don't see a stroke, then you might repeat it if the suspicion is high. And when you see a stroke, you look at the various major risk factors in terms of the lab tests, the cardiac, and if you say cryptogenic, you have run a majority of tests, and you start the treatment. If you have cardioembolic, if you have an AF or a high suspicion of a cardiogenic source, you start on the NOACs. So that's in general the complete algorithm which we follow. But behind that, there is the biggest thing that we should not forget is the risk reduction strategies, which are the cardiovascular, the same as for the cardiac or the heart disease. We should not forget that, and we should be equally aggressive in not just giving antiplatelets or antithrombotics, but also eliminating risks like alcohol, patients taking drugs. Glycemic control is something which I really find very badly controlled from patients coming in from cardiology. They usually have a very high tolerance to A1C, and I personally believe to get it below 6 or 6, and you should use GLP agonist and metformin. GLP-1 are the empagliflozin, DAPA. They should be used with liberally, and SGLT2 like gliptins. So these are the best ones. I think glimepiride should be avoided. That's not supposed to that's not shown great advantage. And be very liberal with your anti-lipid drugs. Get it down to as low as possible. Although the recommendation says LDL should be less than 100, but we should go quite low. The studies have clearly shown that low is not risky. And the BP, definitely 130/80 is the right recommendation as per the recent ASA, AHA guidelines. Other things like lipids, one should take care of the obesity. Weight loss is extremely important. Physical activity is another thing that we should specify to the patients, the kind which increases your heart rate. Smoking cessation, stimulants should be also be avoided. So looking at the most important crux of secondary prevention is antithrombotic. So I'll spend some time on the antithrombotics, why and when, which ones should we use, and what's new and what are the recommendations. So why it's a no-brainer. Why we should use it? We know that post TIA, the stroke risk happens just like I said. Both post TIA and stroke, there's a very high risk of a stroke in the first 30 days till 5 years, as shown in the previous slides too. That'll keep on happening, and the harms are immense. The death rates are high, and morbidity is high, and the deaths may even up to that death may occur to the tune of 20% in 1 year, up to 35% in 5 years, and there is functional dependence. So we need to treat them for all different subtypes. If we start from these large artery atherosclerotic disease, small vessel atherosclerotic disease, ignore the ICH and SAH, all have almost one common strategy, excepting the cardioembolic, which is antiplatelets. So in general, we use antiplatelets for most of the subtypes, small vessel, large vessel, even cryptogenic till the time we don't prove anything, or even the rare causes like some of the prothrombotic states, they do as well with antithrombotics. So we should know our antithrombotics or antiplatelets like the back of our hands. The DOACs is what I consider as the most important thing for cardioembolics, and the not warfarin but DOACs now. And I would not really spend much time on them because that will be another talk in itself. So if we look at large artery, other determinants, small vessel, cryptogenic, all of them usually are responsive to use of either dual or single. So antiplatelets are the most important things that we should know of, and that's why we should know a lot. We should use antiplatelets or antithrombotics. How soon? Now that's a question. Now we have clear answers, but years back the answers were not clear. So I'll just take you through the earlier landmark studies, which actually helped us understand how soon should we. It seems like a common thing we say started immediately after a stroke now, but earlier people were delaying use of those antiplatelets. And this paper by Clay Johnston, and by the way, Clay Johnston is the same person who after that has the most, I think, landmark antiplatelet trials for secondary prevention of stroke, including Chance Point, etc. So this was done in an emergency, and what was seen that within 90 days of a stroke after TIA, there was a 10.5% incidence of stroke in the first 90 days of a TIA. However, the biggest part was, which was an eye opener, that half of these happened in the first 48 hours. So early stroke incidence after a TIA is a big risk, and we should not forget it. And that's why even if we look at post reperfusion, there is reocclusion of a good number of arteries. And for these very reasons, early use of aspirin is required and is indicated. And a long time back, we had the major clinical trials, the CAST, if you remember, one of the earliest large volume trials, and the International Stroke Trial, which actually put the stamp on aspirin as one of the best agents in stroke. And we no point in discussing that right now, but across all variables, aspirin did better at any age, any race, any gender, any age, uh, whatever time you started. Aspirin favored the prevention of a stroke or death. And these were the two landmark trials that happened. So which antithrombotic should we use? A host of trials have been done. And if we look at all the trials, I will not discuss all the trials, but importantly, they're either in the early years, both single as well as DOACs were dual anti, sorry, not DOACs, but dual antiplatelets were tried. There's a huge number of trials. What needs to be specified here that only few of the trials looked at ischemic stroke as a secondary prevention, which makes them more important studies rather than looking at death. Somehow it was probably not clear that's what is more common. So they use death or ischemic stroke as the outcome. So more important is when the trials which used stroke or a TIA following a stroke as the outcome. And if we looked at most of these earlier trials, uh, most of them did not even show the significance because probably of wrong design. They were looking at depth. But if you looked at the cast, like the one which I said, although it looked at depth, it did show reduction because this was a follow-up of 4 week, and it showed that even early deaths could be prevented with stroke. But when they analyzed, the ischemic strokes were also way lower with single antiplatelets. So different antiplatelets which work at different sites of action. We are commonly aspirin, the COX-1 inhibitor. We have cilostazol and diphenylamine, which is a PDE3 inhibitor. And we do have the common clopidogrel as ADP antagonists and the other grels, which so all of them are now being tested in different trials for stroke. The advantage of having different antiplatelets is that, and all of these have variable indications have been tried. Various antiplatelets and various indications have been tried. So between the single antiplatelets, these all have been tried. I would not take you through all of the trials, but clearly aspirin at all doses, that's more important because this was the earlier times when all doses were tried. We now know that even 75 is as good as 1 gram. So it's basically recommended as 75 to 150. The Capri showed clopidogrel being more effective with peripheral arterial disease. The Socrates, which looked at ticagrelor, and again done by Clay Johnston, the trials which look at ticagrelor. However, there were a huge number of bleeds with the ticagrelor, and it was not found to be superior to aspirin in reducing the rate of stroke. That's when they looked at all the three endpoints, but for stroke alone, it was not. Cilostazol, chiefly it was studied in the Japanese, but more importantly, the Chance and the Point, which every one of us are very familiar with. So Chance trial got published earlier, and sorry. So Chance two basically looked at the ticagrelor versus, this is a single antiplatelet versus uh, clopidogrel and aspirin. And this also, although it did almost showed better results in the incidence with ticagrelor and aspirin, and the chance 2 did show some benefits. The only problem with double antiplatelets is although they work at two different mechanisms, so that's the rationale of using it, and they may be more effective. We suffer from higher bleeding rates. So the earliest were the ESPS2. I won't go in the details. The aspirin and dipyridamole. Clearly, they two, and for a long period of time, this had become a standard, but because of side effects, it was not very frequently used, and we saw that the dual aspirin dipyridamole was more effective than aspirin alone. And the meta-analysis also showed most of the things, parameters in most of the trials, they favored the aspirin and dipyridamole. However, the side effects, they limited the use, the headache especially, and the cardiac ischemia. So they did not become popular. And this was also, the aspirin dipyridamole was not tested in the US. We should remember one major thing, and they were never in part of the guidelines, mostly, which were published. The Profess also looked at the similar thing, but again did not show superiority of aspirin with dipyridamole with clopidogrel, and almost was similar, which kind of put clopidogrel into the timeline, and aspirin. So the other ones which really showed some effect was clopidogrel aspirin. Later on, earlier trials of aspirin clopidogrel were negative, in fact. And if we looked at the first ones, which was the match trial, if you remember from things of the past, we still found aspirin clopidogrel to be dangerous, but they got researched with chance and the point. So when the chance got published, we first saw that dual antiplatelets were useful for a short period of time. And this came to us after this major trial, which was the match and the charisma. These were the two trials which did not show in very robust difference between the two, between aspirin clopidogrel and clopidogrel, but higher bleeding rates kind of took them off. However, we missed the point where they probably were useful, which was the early part of the dual antiplatelet time, and the bleeding rates initially removed the dual antiplatelets from use, and this is 2004. But when chance and point came, and this was based upon some previous data which were analyzed, where they did find that it was probably useful only for the first few weeks, and chance got published before point. However, point trial for information that started earlier than chance, and point used a different regimen than chance. Again, a dual antiplatelet which was tested for the 21 days post stroke showed much better results with the clopidogrel aspirin versus the aspirin, and also survival as well as stroke. And this was primarily seen in the first 21 days. The hemorrhages were also not high. It was only actually when the meta-analysis which showed that the hemorrhage rates and the benefit of the dual antiplatelets, it started crossing each other beyond the third week. And the pooled analysis simply showed this fact, which helped us establish the period, duration for which dual antiplatelets should be given. Looking at this graph, the ischemic events and the hemorrhages, they started converging after the third week. So they both reached a baseline. So there was no point in using a dual beyond this, because hemorrhage rates were still high, but the benefit was reducing. So that is the reason this 21-day time point was reached, where we could balance out the major hemorrhages and the benefits of an ischemic event. Ticagrelor, why that has come in? Because clopidogrel is a prodrug, as you all know. It's an oxoclopidogrel. It forms oxoclopidogrel. So when a lot of Asians especially have the CYP2C allele, which prevents clopidogrel from getting activated, and that's one of our biggest fear, that it may not be acting. So ticagrelor is a good alternative, and aspirin ticagrelor may actually has been shown in some of the trials. Thales was the one which was initially, actually they powered it to detect a hazard of 0.88, and later on it was readjusted when they looked at data from the other trials, and this did show a benefit. Again, it's SC Johnston. Yes, and similarly, Celestine was tested in the Japanese, which did show benefit, but somehow it has not picked up in other parts of the world. I would not spend much time on this. Basically, this is showing the effect on cardiomyopathic versus a non-cardiomyopathic strokes, where how do you use after revascularization. So if you have given a thrombolysis or even an MT, you will wait for 24 hours before restarting. Currently, there are trials which are testing use even after the recanalization, and we still are not sure whether this will be useful. And the reason is, even after you recanalize, there is a big chance of a clot to reform. Uh, Basically, this can be avoided. This is a point I was trying to make, that most of the trials included in the meta-analysis were the ones on drugs which are available in the US, and that's why this photograph. They removed most of the trials which did not have the non-US available drugs like ticagrelor, cilostazol, or even dipridamole. So I could avoid this. It's the same as short and long duration. And so in valvular heart disease, antithrombotics, this would be the other part, apart from the use in use of in the general stroke. When you have cardiomyopathic strokes with AF versus valvular heart disease, we know that currently class 1 evidence is there for DOACs for non-valvular AF. If it's a valvular, which we face very commonly, the rheumatic heart disease patients, warfarin adjusted to 2 to 3, and if it's a replaced valve, you need higher INR, though those need to be tested. And in a cardiomyopathy, usually, again, with different aspects of cardiomyopathy, warfarin has been still recommended. And although there is no data on low EF, the WARSEF was a negative trial, but we tend to treat patients with anticoagulants because this happens commonly in practice when you don't find any other cause of the stroke in a large artery atherosclerotic disease or something. This in general is the guidelines as per whatever evidence we have accrued. So the American guidelines simply tell us to use aspirin within 24, after 24 to 48 hours after thrombolysis, especially if it has been treated with IVT, delay 24 hours, and DAPT with aspirin clopidogrel is recommended within 24 hours. However, this differs in the European guidelines, where they do mention dipyridamole plus aspirin or clopidogrel alone for non even till date. I don't know if that's updated, but the last guideline did mention these. Probably they would have updated now with other available antiplatelets, but this has been the standard European guideline. And there's a class 2A, basically other categories like ICAD and ECAD. You may extend the dual antiplatelets for 30 days, which includes either aspirin clopidogrel or aspirin ticagrelor. You may take it for 30 days for non-significant ECAD, or ICAD, which is greater than 30%. There is harm for using it more than 90 days. That's based on the Charisma and the Match trial. So ideally, you should not be using. However, in practice, you may be noticing the cardiologist using dual antiplatelets, and we even sometimes forget to stop it. But that may increase your bleeding risk. One has to be. So other things like 11A and other newer drugs are being tested. Some of them have shown to be of not to be of benefit. However, other strategies are also being tested, like antiplatelets to oral anticoagulation, and both combination of atherothrombotic and AF, and similarly in ICAD using NOACs with aspirin. So these are interesting studies. Some of them have already come out to be negative for ICAD. The Captiva study, I think, is negative now, which compared the anticoagulation in ICAD. So at the end, important part is use single or dual antiplatelets as per the recommendations, and you will achieve a good risk reduction of 35% in the recurrence, which is huge. And we've looked at the kind of recurrences which happen early within 30 days as well as up to 5 years. So the right kind of antiplatelet need to be used. And usually if you are able, you feel that there is some resistance or a recurrence or a minor TIA happening on some antiplatelet, you can now have the choice of taking them to other antiplatelet like cilostazol or ticagrelor, which we are commonly using, since they act at different with a different mechanism, and probably they are the answer to the resistance that you have. So combination should not be forgotten that statins and other risk factors need to be controlled. We're still awaiting trials for 11A, which may give us some new hope. And with that, hoping that we get better antiplatelets and which have still lower risks of recurrent strokes, we may be able to prevent more disability. Thank you.
Thank you, Dr. Dheeraj. That was a very comprehensive coverage of the topic. I think a very important thing here is the treatment of how we manage TAAs, especially at the ED level. Very often they come with a TAA or a minor stroke. They're asked to see a neurologist tomorrow morning, by which time they have had a major stroke. I think we need to emphasize this treatment of TAA a lot.
I agree, sir. And basically, the ABCD scores have been very well highlighted. I didn't take that up because time didn't allow it. But if you use ABCD2 and teach your nurses how to do it, it's actually meant for the nurses. ABCD2 was developed for the emergency nurses in the UK. And they can very well figure out, even at that level, which patient needs to be admitted for a stroke in which has a high risk of a stroke in the first 24 hours till 1 week. And treatment of TIA, agreeable, that needs to be emphasized, especially in the peripheral levels, because many times we get patients who went with the TIA and the doctor just prescribed them antihypertensive. Your BP was high, BP will be high because that's a response of a ischemia. And not even an antiplatelet is started. And sometimes quite often we have seen strokes happening within the next 24 hours. And they land up in the emergency because somebody in the periphery didn't treat them.
Quite right.
Dheeraj, I wanted to ask you, now this thing of using tirofiban after giving altiplase, TNK has come as soon as the drip is over. So this 24-48 hours waiting, is it going out of the window?
The Chinese trial on tirofiban, that's what you're talking of. That basically, which was published a month or two back, that's for early neurological deterioration. So that should not be interpreted as just starting after every thrombolysis. They have shown tirofiban to be useful in cases of early neurological deterioration, meaning you wait in the first few hours or maybe first 24 hours. I think it went on to 48 to 72 hours or maybe early few hours. I don't remember the time. If you had the patient deteriorating, then they gave it for a week. The infusion was given for a week. Not all patients. You may land up with bleeds. So tirofiban is IV, and you need to use it selectively in patients with neurological deterioration.
Can give it before 24 hours.
Your voice is breaking. Your voice is breaking, Nasreen.
More hemorrhage.
No, we can't hear the. Please come again.
Can you please repeat?
There is no trial or no study to show that you should wait for 24 hours. It's just an assumption for purposes of safety. But that thing may change, because now that people are using, even for early neurological deterioration, tirofiban within 6 hours or 8 hours or 12 hours.
Yes.
Where does that waiting for 24 hours go?
So we don't have to wait for early. That's what I said. How early? We're still not sure.
Yeah.
But maybe you can use surrogates. Then it would just imply doing more tests. Like if you have you're anyways doing an MT and post MT too. By the way, now intra-arterial TNK and TP is still being recommended, which the interventionists need to be updated on. They don't wait for that, and even you can use the intra-arterial thrombolysis post that. So this will get clearer, I think, in the coming, because now a lot of trials are now adding on. People are becoming more adventurous. The early era of thrombolysis where everything was, oh no, don't touch, don't touch.
Correct. So all that no thing is going away.
Yeah. So
All
fear
this
has to go, of
no,
course.
no,
Now it's, we
don't
don't
do
even,
this, don't do that.
yeah.
These things are getting whittled off,
True, true. So
Yeah,
the confidence is building faster,
yeah,
and that it's basically a psychological fear. You're using a clot busting drug, the bleed may happen because that's the only thing
yeah.
everybody fears:
So it's
bleed,
an
bleed, bleed.
assumption. See,
Yeah.
there's no trial. It's an assumption.
So if you have a right patient, you have the perfectly chosen patient. That's how I see our patients day in and day. Like currently, we are very routinely thrombolizing up till 18 hours, 19 hours, and I have like
Yes.
in a month we thrombolize close to 22, 23 patients now, and way higher than MT. And we are having hardly any bleeds using, of course,
Yes.
perfusion. I'm not saying we just go to
Absolutely.
18, 19 hours.
Absolutely.
Perfusion or MR based, we have practically 18, 19 hours. And the confidence is really high now, even with my residents, because we discussed every case is, looked at as a single, selected basis. And this tool of the perfusion, the advanced imaging is the biggest thing that has helped us advance thrombolysis, I would say.
What are you doing? CT based or MR based?
Both.
Advanced
If
imaging.
MR is available, up till 9 hours, we know that, or up
Yeah,
to
we have evidence to 9 hours we have.
but
Yes.
beyond 7 to 8 hours, CTP is done in all cases. For us, it's a standard protocol. Our protocol is post 6 hours, everybody undergoes CTA, CTP. So if somehow, sometimes MR is also available, we get both the things done. If sometimes patient moves in a CTP. So we can't interpret the CTP. Then we reveal him to the MR, and if we get a mismatch, it's very easy. So these things have become now really becoming helpful for the patient.
Dheeraj,
Yeah,
are you giving IV TPA even beyond 9 hours?
Oh yeah,
That's what
that's
it
what I
said.
said. I'm presenting the same data in WSC up till 19 hours. Till 19 hours we have been giving it now, and there are papers to do. There's ample data on this. Beyond up till 9 to 12 hours, so we can extend to
The
any
TNK
number of
was
hours.
tested up to 24 hours. No,
Yeah,
recently we
the
have
rule is the
this
same
trial.
as MT. So if you have a penumbra, there is no reason to fear. That's the biggest learning we've had.
Absolutely.
And there's a trial already ongoing in India, and I think AIMS Awadh is doing, which was funded a few years back. He's also going up to 24 hours for looking at the same. So we have real world evidence. We have close to around
One
50
more thing that sorry. One more
Yeah.
thing that I do is after 12 hours, I start off on aspirin and atorvastatin in patients where
So
I
right,
think
we could do
high
that.
risk of
Yeah,
END.
but even I'm quite I concur that because TPA only stays or TNK stays for a half-life of say 1 hour.
Minutes to hours.
It's got a T half is very T half for TNK is higher than TPA, but by the 12 hours it's almost gone off the circulation. So there is practically no reason we should not give it, but the rules stick to 24 hours.
Dheeraj, I please allow me to ask you one question.
Sir.
No. I mean, we are very enthusiastic to extend this IV thrombolysis up to 24 hours. But the problem is in the guidelines. In the guidelines, no guideline is supporting it. So you are not worried about the legal parts and other things.
So we inform the patient, and get a sign, we get a consent that we are doing it. So we have data to do this, and we tell the patient that this is how we can use it, and it's a disability or no disability. The patient is consigning the consent. We do mention that we have been explained the risks and benefits for the same.
So much it has come in some guideline, huh?
No,
Right?
not up
No,
to
it has
Not up
come.
till 24
It has
hours, but
come.
you have guidelines up till for wake up till 9 hours. It's already there in the guidelines, in the AHA guidelines.
It's up to 9 hours. I agree. Up to
Yeah,
9 hours.
so
No,
again,
even after
guidelines,
that, I'll send
as
it to
we
you.
all
I read it recently.
understand,
So it's
guidelines.
come in some guideline. I don't remember which
So
guideline, but
last
some
guideline is
country
the
has
AHA guideline 2021. There's nothing beyond that.
Shall we take
21,
this
there's
up
no.
in the panel
to you
discussion?
later on. As soon as. Okay, I have to leave. So, Dr. Gilwas, could you kindly take over, please? I have to
Okay.
attend another lecture. Thank you so much.
I'm just fine.
Thanks.
I'm
Bye,
fine.
everyone. Thank you.
Bye.
So next on, we have a very interesting talk of beyond thrombolysis. And for this, we have Dr. Fiju Chako. He happens to be from my institution. He is the present professor and head of the Department of Neurology. A very proactive neurologist, keen on stroke, epilepsy, and neurocritical care, multiple national publications. And he began very, very sharply as well with a gold medal in general medicine and recognized by most societies. So over to you, Fiju.
Thank you, team. Let me share the screen.
Yes, sir. Please go ahead, sir.
Yeah. Thank you for being part of this stroke symposium, and thank you, team Genova. And we'll have a case discussed: spontaneous recanalization post IV thrombolysis. This is a case of a 64-year-old gentleman who had a stroke, a right hemiparesis with aphasia. He reached our hospital within 90 minutes. At the emergency services, his non-contrast CT showed an aspect 7, and CT angio was done after thrombolysis. CT angio after IV TNK, we gave only 0.2 milligram per kg, and that confirmed an occlusion of the left MCA-M1. IV tenectase was given, at 30 minutes of arrival in hospital, and we were discussing DSA and mechanical thrombectomy. Patient brother was a doctor. We were waiting for him, and there was some delay of around 2 hours for them to decide on mechanical thrombectomy. I'll show the slides. For the last 6 years, we have a public announcement that is code 7, acute stroke, in the public announcement all over the hospital, and we rush the patient to CT with just a glucometer RBs. And we do the IV tenectase at the CT console itself. Earlier, we used to get them back to the neuro ICU or the emergency services, and that was taking time. Now, our team of senior residents and nurses go to the CT console and give the shoot at where the event happening at the CT, and after the thrombolysis, we do the CT angio. This is the first CT showing aspect 7. And this is the CT angio showing an M1 cutoff. On the right side, it's fine. On the left side, it's a cutoff. These vessels are not clear. This is the CT angio soon after the tenectase was given. And we could do they consented once the brother doctor came, they consented for the DSA and mechanical thrombectomy, and DSA showed a spontaneous recanalization. The M1, which was cut off initially, there's a spontaneous recanalization. The NIHSS also improved. Despite initial CT angio confirming persistent occlusion, patient showed early clinical improvement after IV thrombolysis. This was not immediate. This was the aphasia improved partially. He could speak some words with some Broca's aphasia. Initially, it was total aphasia. Then the right side power improved from grade 1 to grade 3. Just to sum up the case, initial CT showing aspect 7, CT angio soon after tenectase showing an M1 cutoff, and there was a 2-hour gap before the DSA could be done. We were planning mechanical thrombectomy. The NIHSS improved from 14 to 10, and the power improved from grade 1 to grade 3, and aphasia improved partially. The DSA showed at 4.5 hours after the onset of stroke, the recanalization improved. The points to be discussed are role of IV thrombolysis, even in clear LVO. We had some discussion in 2 cases before. In those where we shoot and shift to the cath lab, even then, IV thrombolysis is the step 1, and in up to 20 or 30%, 1 in 5 to even 1 in 3, there is a delayed recanalization after initial thrombolysis. Despite a persistent large vessel occlusion, this is well documented. It's not a rare phenomenon. It's seen from 20 to 33% of cases this is reported, and the importance of clinical improvement guiding the intervention strategies. How common? It's not uncommon. Say at least 1 in 4, even up to 1 in 4, they can improve even large vessel occlusion. These are described as delayed or interval recanalization after thrombolysis. This is more in M2 or M3 and less common in a mainstem MCA or a distal IC. The tenective place is, we had several studies, Dr. SMS clearly showed the benefit due to its higher fibrin specificity and longer half-life compared to Altiplase, having a slightly better chance or increased rate of early and delayed spontaneous recanalization post-growing puncture, with the reports rate is up to 20 to 30% in some series, especially where there is a short onset to needle time and a smaller clot burden. The timing, this usually happens within 60 to 120 minutes after thrombolysis. And as Dr. Dheeraj told just now, the half-life of the drug, both Altiplase and this is less than a few minutes to half an hour or so. The effect is less just for next few hours only. Very late decanalization, even after 6 hours, do occur, but it is rare. They are described, especially in intracranial occlusion, with a partial contrast penetrating sign like a string sign or a thrombus softening. What are the take-home messages? We'll have a discussion shortly. Always reassess the clinical status of patient post-IVTP. We have to monitor every 15 minutes for a BP to see if there's a worsening of NHSs or a BP shoot-up. Imaging is a point in time, a snapshot, and clot dynamics are real time. It varies with time, they're dynamic. DSA confirmation avoids unnecessary device deployment, and when DSA shows no occlusion, despite confirmed LVO in a CT angio, it's not an imaging error. This is referred to as a vanishing thrombus. This is the effect of the earlier lysis. Always worth rechecking on DSA before crossing the lesion. Many centers now they do a diagnostic angiogram first rather than a direct mechanical thrombectomy. You touch and the whole lot falls. Maybe it's mechanical. You touch and everything is clear. And let me say we had around 2,000 IV thrombolysis in our institution and around 400 interventional procedures. Thank you.
Thank you, Fiju. Are there any questions which we'd like to raise right now, or we'll take them with the panel discussion?
Yes, sir. We'll do at the end, sir.
Yeah. So we'll go on with our next talk. Next up, we have Dr. Vijaya, who needs absolutely no introduction. Her honors and awards are phenomenal. She's the president of the ISA, so we don't have to take too much of her time. So over to you, ma'am.
Thank you, sir. Thank you so much. Let me share my screen. So, good evening, everyone. I think my predecessors have set the stage already with a lot of information and very challenging questions also as well. So let me go through briefly to what is new in stroke thrombolysis or acute ischemic stroke. Okay. What's new in IV thrombolysis? Newer agents and adjuvant therapies, mechanical thrombectomy. Most important is the low-cost solutions that has been coming up, systems of care, Indian perspective, and rehabilitation. How do we move this? Okay. Tenecteplase era has been discussed. I think it has become the now standard of care. And this has been discussed by the previous speaker. And it has definite advantages of a higher potency and higher fibrin specificity and also resistance to degradation with a higher plasma half-life. There are a lot of studies going on and more in the coming years. It has been taken up first by the Canadian stroke guidelines, later by USO, and then finally by the FDA. So now that we have a definite evidence for tenecteplase, what is new in this? This is another recent meta-analysis of this molecule, which has shown that TNK at 0.25 milligram per kg is the recommended dose. There is no further testing about 0.1 or 0.4 anymore. The debate has been going on for the last decade, but now we are sure. This meta-analysis shows 0.25 is considered optimal dose and safe, effective alternative to alteplase. This is the recent data. The other one is a Chinese study where the ease of giving tenecteplase has been taken up in the community hospitals. It has a marginally better outcome in 72.7 versus 70% with alteplase. And this is another subgroup analysis of ACT trial, which the pragmatic trial, which changed the scenario for tenecteplase by Vijay Menon and team. Faster thrombolysis is associated with the improved cognitive outcomes. As we are measuring not just the NIH score, but also short-term and long-term cognitive outcomes of these stroke patients. Because tenecteplase allows us earlier thrombolysis and earlier recanalization, it will make a difference in the long-term cognitive improvement. That is what this study is a sub-study of this implies. And this is another one in NEJM. Can I do this one? Can I minimize this? Okay. NEJM, this says intravenous tenecteplase before thrombectomy in stroke. This has been head-to-head comparison like alteplase they did in the Hermes collaboration studies. Here they tested with tenecteplase plus MT or just MT alone. In this study, it has been clearly shown MT before tenecteplase before MT is beneficial than direct MT alone. This is again another new evidence that we got in the NEJM. Okay. And this is another interesting study where they are testing this beyond 4.5 hours. We have been just discussing. Dheeraj has been telling us that he's doing up 24 hours. I think we'll have our own data soon. It is definitely shown to be safe. Whether it is functional outcome is significant or not, we'll come to know in the next coming years and studies. And coming to other agents, it's not just there are so many host of agents that are being tested for better and better. As we know that so far, nothing has been working 100% of the patients. This is a molecule tried in the Chinese people where it is retiplase, where it is given as a fixed dose. The advantage of this drug is you need not know the weight of the patient. There are 2 doses given 30 minutes apart, and that is versus alteplase. This has been shown to be effective and safe, and it is also supposed to be cheaper. We don't have this molecule in India so far. And another drug they have tested in Russia, the staphylokinase, which is also shown to be effective and safe within 4.5 hours of stroke. And there is a word about adjuvant therapies. A lot of these things are very interesting that I started looking at them. As we know, the thrombus is not just made of RBC alone or fibrin alone. This is where the fibrinolytics, the TNK or alteplase just lies the fibrin associated things. But there are many non-fibrin associated components of the clot which can be targeted for better recanalization. This is a very good concept. And there's so much work is going on in this. The first strategy already discussed newer lytics and safer lytics, including pro-urokinase and anti-steplase. The strategy 2 is a novel drug delivery system to enhance lytic effect of the TPA. Example, nanoparticles can take the drug within the clot so that more drug is available on the surface of the clot. The lysis may be more complete. This is a technique which is there being used. Strategy 3 is targeting fibrinolytic inhibitors. As we know, the action of alteplase or tenecteplase will be cut down by the alpha-2 antiplasmin. Therefore, if you use the inhibitors for this, it may be prolonged effect. The fourth strategy is targeting non-fibrin contents of thrombi, as I was mentioning. When this is a very beautiful picture of a thrombus taken out from a patient, and it is electron microscope immunofluorescence staining showing not just RBC, but DNA, platelet GP1B, and as well as von Willebrand factor, which is a significant component of the clot. If we have some of these agents which can target these things, we can have a better lysis of the clot. Therefore, the future perspectives can be IV fibrinolysis is still the cornerstone of managing acute ischemic stroke, but there's a huge treatment gap as well as unwanted side effects. The quest for more effective and 100% safer lytic continues. Newer lytics as well as innovative drug deliveries to the thrombus and targeting non-fibrin thrombus contents can have synergistic action to improve recanalization rates. Maybe in future we can have a pharmacological cocktail, one neuroprotectant, one adjuvant therapy, and one fibrinolytic coupled with or without mechanical thrombectomy may be the future of the AS lytics treatments. And a word about endovascular therapy. Mechanical thrombectomy is again the standard of care from 2015 following the MR clean study. And lot of data we have across the world. And in India also we have many centers doing these mechanical thrombectomy. This is a review article by Dr. Gigi and the team. And it has also shown successful recanalization rates of MT in India up to 80% to 82%. The first fast recanalization is only about 46%. And what is interesting in this field is we have tested a low cost solution, that is a stent retriever in the grassroots trial, which has just concluded, which has shown success in this multicentric study, started in the AIMS Delhi. And this has been the gravity supernova stent, which is used in these studies, has been given approval. And then we are hoping to use it in the future and see how it helps the poor patients of the country, where it can, if the government endorses this thrombectomy, we can give this effective treatment to all the needy patients in India. This is a very good, exciting thing that happened in this year. And what about the advances in organized stroke care? As we know, stroke is not treated by single person. We need a big team and this system which should be in place. And it's a whole, everybody was talking from Padma to Dheeraj, all of them are talking, Dr. Kaur. We need a big team to treat these patients. How to organize them efficiently and effectively is the challenge that we need to do. Stroke unit is still the basic and the corner and the rock bottom of all these treatments that we are talking about with class 1 level of evidence A. And ideally, every patient of stroke should be treated in the stroke unit. And as I was mentioning, all other things are built on this a good stroke unit care. And we have these primary stroke centers with the core measures that has been measured in India. We are having recently, for the last 2-3 years, we are having accreditation and certification of stroke centers. Only the second country after, I think, US and Canada, and second or third country that are doing this certification of these stroke centers. And we have these primary stroke centers with all these criteria and advanced comprehensive stroke centers which have more than 100 components that should be available 24/7. This may not be possible in every place, but we can have a hub and spoke model to utilize this in the most efficient way. These are the components of the comprehensive stroke centers. This is our advanced stroke center which has been given the first accreditation in India. And in US, we have 4 tiers of hospitals: acute stroke ready, primary stroke center, thrombectomy capable, and comprehensive stroke center. In India, so far we are having primary stroke centers and advanced stroke centers, and we should be making the stroke ready hospitals at the district level, where we can share this job with physicians and emergency physicians. That is another solution to deal with our huge stroke burden, as everyone is mentioning. And so Padma so elusively discussed about this point. These are the 2 bodies that have been giving accreditation in India, QAI, along with ISA and NABH. And of course, the another great thing that happened, the systems of care is the mobile stroke unit, which has been tested in Germany, then Australia and other Western countries. This is very efficient to decrease the time to needle as well as to improve the outcomes. However, it may not be a very efficient model in India. It can be used in remote areas where there is a difficult to reach. And ICMR has tested this in Assam or Guwahati, where it was successful. It's a mobile stroke unit. Technological advances in low cost, low weight CT and MRIs is the future of this concept. If we have a low cost, just like X-ray machine or an ultrasound machine, we can get a good CT or MRI. We can take them to every patient to the house and then get the patient in and then thrombolize them before they reach the hospital. That is an ideal dream of the future for the stroke patients. Tenecteplase is, of course, preferred agent in these MSUs, where it can be given in a bolus of 5 seconds. And what is important is to build the stroke center network. You should have a network of hospitals starting from the district level to the academic center in a hub and spoke model, and also the pre-hospital triage system and a fast transfer system depending on the type of the stroke. This is another next big challenge for India as well as for anywhere in the stroke care. Luckily, our government has taken up this concept from all the stroke leaders, starting from Dr. Jairaj, and all of us are talking about the stroke systems of care and to strengthen them with the different solutions at the grassroots level, at the district level. Hopefully, this will see come into implementation soon and to serve the needy patients of the country. And digital technology, I think Dr. Lakshmi Narasimhan will be dealing with it, and rapid AI and all the AI based. I'll just tell one word about this. This has been the technology with AI based technology has been used to triage the patient. It can read the aspect score, CTS, CTP, and everything in seconds, and then tell us whether to take to the stroke ready hospital or it have to take it to the comprehensive stroke center. These are all being tested in the Western world, and latest MAP stroke study has also shown to be useful in doing this pre-hospital, speeds up time and mechanical thrombectomy center and with better neurological recovery. Optimize the hospital route and pre-hospital triage system. Of course, we have wearable devices and stroke risk monitoring for prevention of stroke. These are also coming up of late. Time is brain. AI can help. How Dr. Lakshmi Narasimhan will tell us. Rehabilitation also is in a big way. We have a lot of advances, robotic assisted therapies to gait training modules to virtual reality to gaming of which has gamification of the stroke recovery, which will also encourage people to stick to it and do it in a vigorous way. And transcranial magnetic stimulation as well as TTTS, all these are used routinely in some of the metro cities in India. And future is to make them available to all the needy patients. And telerehabilitation is a solution for low-cost solution. Telerehabilitation is we'll all discuss in the panel discussion. To summarize, thrombolysis rates remain low in our country due to the delayed presentation and limited CT access and lack of organized stroke care at peripheries. The solution is to develop stroke unit with CT scan and stroke team, physician or ER physician at every district level, to develop a stroke systems of care with hub and spoke model, telethrombolysis, mobile stroke unit in remote areas, continued public and physician education and empowerment. So, in this regard, ISA has taken up the initiative to take this to stroke masterclass for physicians and emergency physicians across India, starting from Guntur, Hyderabad to Jaipur and Raipur, Kolkata, Bhopal. All these are places where we have done this with support from Genova. And we are also doing the public education program on prevention of stroke with Check BP Stop Stroke campaign, which is again we are doing across India to take this message to the masses to prevent stroke. Stroke is preventable, treatable, and recoverable. Teamwork matters. Thank you very much. And from Indian Stroke Association, I bring the best wishes to all of you. Thank you.
Thank you, Dr. Vijaya. We are running short of time, so we'll just go on to the next talk by Dr. Lakshmi Narasimhan, who will be talking to us on what's next, AI, telestroke, and more. Over to you, Lakshmi Narasimhan. Can we have his bio, please?
Sir, it's already on screen.
Ronan sir, no, not visible, sir.
Not visible, yeah.
Yeah, sir.
Okay, I'll just reshare. Just
Yes, sir, please.
Yeah, I think now.
No, I think it is loading, sir. Please wait.
Is it there now?
Yeah, sir. Now it
Yes.
is.
Okay.
Well, Professor Lakshmi Narasimhan was the former HOD of the Madras Medical College and director of the Institute of Neurology, Madras Medical College. He again needs no introduction, a very distinguished neurologist with over 30 to 40 decades of expertise in clinical neurology, a recipient of multiple awards, and the editor of multiple textbooks and publications.
Thank you, sir.
Over
Thank
to
you.
you, Lakshmi Narasimhan.
Thank you, sir. Can you hear me, sir?
Yeah, absolutely.
And screen is visible, sir?
Screen is visible? Absolutely.
Yes, thank you. Because
your slides
I
haven't come on yet.
On a pre-advanced Diwali greetings to every one of you, and I know you'll be very tired after a hectic. I will not take you much time. I'll just finish off. I'll just take you to see this funny clipping.
This record comes to you through the Sales Talk Transcription Company incorporated. Your speaker, the
So
mechanical.
your screen is not visible.
Very famous Charlie Chaplin story.
Inventor of the Billows feeding machine, a practical device which automatically feeds your men while at work.
Sir, your
Lakshmi, we
screen is
can't
not
see your
visible, sir.
screen. Lakshmi,
We can't see your screen.
screen is not seen.
Oh,
So you have to restart from the beginning. You have
Sir,
not
can
got
you
the screen at
reshare?
all now.
Okay. Now it's seen, sir?
Not yet, sir.
No.
Please share your screen.
Is it visible, sir?
Not yet, sir.
So then I'll exit out and then come back again.
Yeah, please do. I think
Sure.
that's the right thing to. That's the way to go.
I'm sorry, sir. I'm sorry about that. Sir, am I connected or I'm not connected, sir?
So you're connected. We can see you, we can hear you well, but your slides are not yet visible, sir.
Now you need to share your slides.
Yeah, I've
Go to
shared.
that share option in the middle, that green one with an arrow.
Share. I've shared.
Yes, sir. Now we can see your screen. Could you please
You
go
need
at
to
the
Pick your
presentation?
presentation next.
Yes, sir. Just a second.
You have to select your presentation, Lakshmi. The screen is seen of your laptop. Yeah, yeah.
It's not getting selected. I don't know why.
Oh. Yeah, yeah. AI in stroke, Lucknow. Yeah.
Yes.
Yes.
Yes, sir. Perfect now. Please go ahead.
Sir, are you able to see the movie, sir?
Yes, sir.
Comes to you through the Sales Talk Transcription Company incorporated.
Here, no, long back they did automation.
This record comes to you through the sterilized mouth pipe.
Yeah, this is an automatic feeder. Just see one of the Charlie Chaplin, very fun. They're testing it with Charlie Chaplin, the feeding machine. Suddenly something goes wrong and so this is about 1940. You can see the imagination. So artificial intelligence, I don't want to. This is quite interesting. I asked the Sri, what is the answer? What is the answer which a wife expects, yes or no? I just typed it in Sri and then it replied, the best answer wife likes is no. I felt that AA is not married. And I don't want to go into this, the machine learning technique and all. So now, right now, in most of the other areas, AI is still in the not on the real world, not in the real world status. But as far as stroke is concerned, it is there in every aspect of stroke. AI for diagnosis there, AI for protocols, prognostication, treatment, rehabilitation, stroke surgery, genomics, and predicting. All things are there. This is one of the very good review in Nature, artificial intelligence. You can see that we use the human intelligence in imaging interpretation and clinical assessment. The same thing is done by automation, non-contrast CT, it does the aspect score, decision support, it also severity of grading. Not only that, CT, it also takes into all the outputs from the clinical, and the NIH is also done based on the, so AI for diagnosis, it is available. AI-inspired methods can improve the quality of medical images, and reconstruction algorithms are there, artificial stroke. And you can see that this is another very interesting thing where it can predict the outcome as well as the imaging and CTR, the lesion on the plain CT, everything is done now. Large vessel occlusion aspects is done, core lesion, salvageable tissue, whether hemorrhage is present or not, how much hemorrhage, everything is done by that. And AI in stroke protocols, AI automates the NIHS, automatic NIHS scoring system available, which also predicts at risk and assess the benefits of the PPA. AI algorithms can identify DWFLR, wake-up strokes, 105 patients with stroke, the indeterminate time indeterminate strokes where the DWFLR mismatch which we use, multimodal magnetic resonance imaging identify within 6 hours and then are they eligible for. And then algorithms can be used now, right now, CT aspects, MRI aspects, anterior circulation, posterior circulation, everything is available right now in AI. AI algorithm, artificial intelligence detections, large vessel occlusion, 9 months, 650 patients evaluated study. In Viz AI, it's LVO algorithm, and presents 82% sensitivity and about 90% specificity. The LVO detection is this is the Viz AI software which detects, and not only that, it detects that this Huron LVO software reduces the time to thrombectomy by automatic LVO and also the collateral detection. AI models can be used to identify the core and at-risk penumbral. The rapid AI, which Madam already talked, that was the one which was used in diffuse trials, and now most of the centers have the AI rapid now. The prediction of hemorrhagic transformation localization after reperfusion therapy in acute stage patients by deep learning. This is a Neurology Green Journal published article. Predicts the hemorrhagic transformation about 89% with a specificity of 60. So these are the few. I'm sorry about the names of. You can see the IDOC, the Avicenna, Brainomics, which Madam showed, Rapid AI, and Viz AI. These are the common top five AI available things in the. They are the available AI for stroke. The AI for prognostication, traditional prognostication, what we do is a modified Rankine scale at 90, informed volume since the time intervention. Collateral status are all able to identify the recovery at 30-40. AI tools use the ML pattern, random forest can be done, reasonably good outcomes. It can predict. Journal Club using gradient boosting machines learning to predict patient outcome in acute ischemic stroke on the basis of imaging. Deep learning in the production, a pilot study was done, it shows better treatment. AI treatment, this is a very interesting study, I just draw your attention. Golden Bridge trial, cluster randomized multi-phase trial with AI did the decision support versus the standard care by the neurophysician. This was a study published, and you see the intervention arm is the AI CDSS protocol, and the control arm is the standard care. The the original diffusion weighted, how does it the structure pattern, how does the watershed, everything is done by the AI image analysis, and the CISA stroke subclassification was done. The results said that using AI-based clinical support system reduced the neovascular by 25.6, and the AI support system is superior as 2.9 versus 3.9. No statistical significance in the outcome. So you can see that the support system is slowly replacing the. You may wonder the empathy factor is not there. Now, recently, the study where they they compare the busy neurophysician and empathy, his empathy versus AA empathy. The questions asked answered by an AA machine from the AA chatbot. The patients felt the chatbot was kind than the experienced neurophysician. This is also published. So the empathy factor is also, and then AA is endovascular thrombectomy. It predicts the success of thrombectomy by analyzing the infarct core size, collateral status in the patient age. AA models provide real-time guidance during the procedure. I know most of the centers here use rapid AA. There are a few centers which have started using Viz also. AI in medical management responds to thrombolysis, anticoagulation, antihypertensive. Machine learning tracks the BP and the coagulation status, identifies the potential complications like stroke surgery. It also, the hematoma expansion is very beautifully picked up early. AI in rehabilitation, madam has shown a few things. Upper limb robot, 15 minutes is too small time for this. So I'm just rushing through. Enhances stroke rehabilitation through robotics, machine learning, assisted robotic arms are there, virtual reality environments, XR gaming has come. These are the few lovely models which say the robotic rehabilitation. This is very interesting. Most of the entire genomics data is integrated with the stroke data. So, for example, you want to choose clopidogrel. If the patient's genetic data is available, it will say whether the patient has got a clopidogrel resistance or not. So the AI models predicts the patient responses to the particular. So this is edging more towards a precision medicine. Similarly, you can see for F11 for coagulation factor 11, kallikrein and PROC for clogged as potential anticoagulation therapy. The CES1 is for the more dabigatran. The CES1 gene polymorphisms affect the metabolite levels of dabigatran and can predict hemorrhage. So in future, I look forward to your genomic data will get integrated, and the moment you are prescribed a medicine, it will go through your genetic background and tell you are a rapid metabolizer of clopidogrel. You have a CYP19 mutation. You are resistant to clopidogrel, or all these things will come up as a prop-up. So this slide, madam also showed. I don't want to show. Predict the outcome. Using the vector model, logistic regression neural networks, predictor includes infarct volume, AA-based outcome predicts and bridge and the wall. Both are made up of bricks. The usage depends upon making wise choice, similar technology can make. I feel that in future, the physician who is going to use AI is going to be more successful than the physicians who are not going to use. But the caveat is, just have a look at this last clipping. I end with this. Are you able to see the voice? So your voice is audible, sir, there? Volume?
The voice is not very audible.
But at least, okay, you can see the
subtitles.
Yeah, you can see the subtitles. You'll be able to understand. A very famous scene in Transcendence. He's a cop. He gets drowned. The two people, he saw a small girl is also drowned. And the robo NS4 is passing by, saw the accident, and breaks open, and you are in danger, and he's begging the NS4 to save the girl. Wants save her, save the girl, is shouting. But it doesn't save her, and it saves him. She dies. It did not respond to my call. It saved me instead. Because it calculates, it's a different engine. Reading vital signs, but it calculated that your survival chance, you are the logical choice because your survival chances is higher. 12% was the survival chance for the girl. So it didn't save. So that's why, Sarah had only 11% survival. This, he says, just a machine. I would have been there. I would have definitely tried to say that is the difference between the human. I'm also scared that the more and more of AI. I don't know what is going to be the interpersonal relationships. Thank you so much for the attention.
Yeah, very nice.
Yeah, thank you, Dr. Lakshmi Narasimhan.
Yes, sir.
I think the next thing planned is a panel discussion. Do we have many of our panelists? Do we have any questions which have been raised by the audience?
No questions in the chat box, sir. So based on the previous sessions, if there is anything that needs to be discussed, although after the sessions, a few of the points were discussed, but sir, your thoughts, Gilwas sir, Vijaya ma'am, SMS sir, Dr. Piju, Dr. Subhash Kaul, and of course, Dr. Lakshmi Narasimhan sir.
Everybody is in the festive mood. I tell you, all family are all waiting there in the house. The moment they saw me hooked into this meeting, they were really, they are furious. They save us for this. I think Professor Gilwas will understand that, sir, we are only one day before the Diwali, and this is absolutely the, if you had created a cracker show, we would have all been enjoyed and joined here instead of a stroke show.
I think now we have multiple.
Sir, I have a comment to make.
Yeah.
Yeah.
Can I, sir? This is what Dr. Fiju sir said, just sharing a experience which happened for us, real-time experience. We took up enthusiastically the idea of thrombolizing, Dr. Fiju sir. We are thrombolizing only in the console, in the CT console. So we'd walk in and thrombolize there. It was saving a lot of time. In fact, we had some data on that also. But one unfortunate patient really changed it. One of the patients, during that time, he had a cardiac arrest. And we had called our code blue team and they came and did everything. But then it becomes nasty in front of the public because they feel that you don't have good many facilities in your CT scan room, which we have in the emergency room. And a lot of questions came up. It came for an audit meet. They said, why did you thrombolize there? You could have done it takes only a couple of minutes to shift to the room where you have more safety. We said, sir, we never had this experience in the past. There's one odd event which really changed our, nowadays we shift back. So any comments on this, sir? Anybody had such experience in the past?
When things go well, everybody is happy, no? And when things go wrong, that's when the buck stops.
99% it goes well, but one patient really changes everything.
That's it.
I think if your ER is nearer to the, sorry, you get it. If the ER is nearer to the scan, we think better to shift to the ER and give it in the ER at least. I agree with that issues of
So
social
actually,
problems.
madam, in our place, we have the crash cart there. We have the crash cart there stationed in the CT room itself. And the qualified, the ER person is also there when we thrombolize them. So as a team, we move to the ER. You are talking about the remote centers where thrombolize, where those things may not be available. In a good center, in a fully evolved centers, the crash cart and the ER support is always there in the CT gang room itself.
It is not the availability, Anna. It is not the availability. It is a public image. Everything is available for us there, but something goes wrong. No, the question starts keep rising up. That is what happened in that patient. We had everything there. We did everything there.
We have the neuro.
It is a public
can happen in
image.
the ER also.
Then you are more safe in the eyes of the public. Huh?
Post lysis, we ship them to ER, and then we have to ship back for the CT angio.
Yeah, sure, sir. We are doing it. That's one odd issue I raised. No, we have everything there in the ER. This one, it is only a minute away from our ER. It's not a long distance for us. Just you have to cross, and a minute you are there.
What we do is,
but in the
we do the plain
eyes of the
CT, we
patient,
thrombolize, and then we do the CT angio there itself, and then shift the back patient back. Now we don't shift
That's
to ER
what we
and
do
then
as
go back.
well.
Connected
That's what
place,
we do as
we
well.
give there, do the CT angio, and then shift the patient back.
That's what we do.
But anyway, this is a eye opener. We should be very careful about cardiac patients at least. As you were saying, if it was pre-existing cardiac disease is there, we should be a little more careful. Every experience teaches us new things. I agree.
I'll also share a good experience which my friend Dr. Balmurugan taught me, madam. We have difficulties in telling patients convincing, and he has written a very nice textbook on awareness of stroke. It's one of the most beautiful books. It is in Tamil. It can't be translated into English. The reason is because a lot of humor has been added into it. But one essential point which I have shared which makes very much comfortable for us to convince patients about use of ventilator, because after all, we are convinced about it. He tells patients this following thing: when the patients come and says, will there be a guarantee? Will my patient walk? Will my patient be able to run? Will he speak well? Will there not be any complications? These questions keep coming up, and one after the other relatives keep pouring in. So he uses one important analogy. He says, if there is a fire in your house and I am the fireman coming there, and you are just calling me and telling me you should enter and take out all the documents from the second floor, and in the Gubera Vasal, there are a lot of money come, you have to bring it back to me, and you should repair everything there, and the house should be the same way as it was before you went inside. So you give this analogy, 100% acceptance comes.
Nice analogy, Meenakshi.
Dr. Balmurugan taught me, sir, not mine. He's my guru. He's in Salem.
Okay.
Anna, Lakshmi Anna knows him very
Good
well. It is written in the book also. Huh?
It's a very good one.
Very good, yeah. So if we have no more,
very good. Yes, sir.
do we have any more questions, or shall we retire for Deepavali and Dhanteras?
You all are happy.
Right.
Yes, sir. Yes, sir.
So
Happy
as we
Diwali
conclude
to all
today's
of you.
session on shaping stroke care, it's clear that progress in stroke management depends on our continued commitment to evidence-based practice, interdisciplinary collaboration, and innovation. Every advancement, whether in acute intervention, rehabilitation, or long-term prevention, ultimately translates into better patient outcomes and quality of life. So let's continue to challenge existing paradigms, apply what we've learned, and work together to shape a more responsive, equitable, and effective stroke care system. Thank you all so very much. I thank the panelists. I thank the audience.
Thank you so much, sir. Yeah, I would like to invite Mr. Deepak Paliwal to please give the vote of thanks for today.
Yeah, good evening, everyone. I am
Sir,
Deepak.
Before you, so I just wanted to place it on record the great services done by the Stroke Association, our president of the Indian Stroke Association, Professor Vidya. She has taken it to almost every nook and corner of India. Previously, in fact, Professor Nirmal Surya started the whole mission, and now this efficiently the task has been carried out by Professor Vijay, and subsequently the thrust for mechanical thrombectomy is going to be given by Vikram Hude also. So I'm very, very happy the way in which the stroke care progresses in India. Thank you so much, Parag. I want to congratulate you and bless and pray that God give you more and more blessings. Thank you.
Thank you. Thank you, sir. Thanks, everyone.
Yes, Mr.
Yeah,
I'm sorry, Mr. Deepak. Please.
Yeah, thank you, doctors. It was really a great honor to have you all in today's Genova Stroke Symposium. And I would like to express my sincere gratitude to Dr. P.C. Gilwas, who is in States, but he took out the time to navigate the entire meeting. Dr. Isha Puria, Dr. M.V. Padma, Dr. Subhash Kaul, Dr. Meenakshi Sundaram, Dr. Dheeraj Khurana, Dr. Fiju Chaku, Dr. P. Vijay, and Dr. Lakshmi Narasimham. Very comprehensive presentation, very immersive learnings. I'm sure all the participants must have been immensely benefited with all the perspectives shared by the experts. Just one line, I would like to reiterate our commitment to the stroke care. We are actively engaged to strengthen the stroke awareness in India, collaborating with the fraternity, especially neurology, to extend the rate of thrombolysis by the neurologists, emergency physicians, and physicians in India, and also to build the public-private partnerships with policymakers for improved stroke ecosystem in India. With this, thank you so much, doctors, for taking out your valuable time, especially during this festive time. Happy Dhanteras to you and your entire family members. Thank you so much. Namaskar.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you. Thanks, everyone.
Recording stopped.
Good night. Good night, sir.
Good night.
Professor Gilwas, sir, and everyone.